what's going on. And so we expect and hope that with this increasing interest in the subspecialty, we should be seeing more research, more development, and more options for medical therapy in our patients with neuro-ophthalmological disorders. So again, thank you for coming, and I think we will start the day sessions of the workshop, and I would request my co-chairpersons of this session, Dr. Swati, Dr. Rebecca, and Dr. Amar, to please come on the dais. The sessions are designed in such a way that our initial discussion is going to be on the basic workup, understanding the investigations that are involved, and subsequently in the second session we'll be looking more at approach to disease and how to manage these conditions. So I think we'll start for the first one. We have Dr. Aishwarya, who will be talking to us about history and clinical examination in neuro-ophthalmology. Dr. Aishwarya.
Can I have the presentation, please?
स्लाइड्स नहीं हो रहा है एक्शन में स्लाइड्स नहीं मैं अपना लैपटॉप दे दीजिए
आप ना रीटेस्ट कर लीजिएगा सारी प्रेजेंटेशंस चल रही हैं कि नहीं।
वो एक्चुअली चल रही है एक्शन मोड पे नहीं आ रहा ना एक्शन मोड पे नहीं आ रहा उसको स्लाइड डुप्लीकेट भी करो अपना लैपटॉप दे दीजिए
प्रेजेंटेशन की प्रॉब्लम थोड़ी है।
नहीं डुप्लीकेट पे नहीं आ रहा
प्रॉब्लम प्रेजेंटेशन की हाँ तो चला तो देखा तो ठीक था।
अगर नहीं है तो दूसरा लैपटॉप लगा दें क्या? कोई क्या इशू है?
अपना लैपटॉप ले दीजिए।
प्लीज टेस्ट करिए सारी प्रेजेंटेशंस बिफोर यू अपलोड देम।
दे दीजिएगा ना मेरे को आप डुप्लीकेट नहीं चल रहा डुप्लीकेट पे चल डुप्लीकेट पे चल
Good morning, everyone. First of all, I'd like to thank Professor Rohit, Dr. Rebecca, Dr. Swati, and Dr. Amar for giving me this opportunity to start this wonderful workshop and be the opening batsman for this academic feast, as Sir puts it. So, as for any aspect of science, it is important to start with the basics that form the foundation of any course of any scientific arena. Okay? So, we are going to start this workshop with the basics, that is history and examination. It is important, like in all branches of medicine, a complete and thorough history be taken from the patient, since it gives the clues to the specific examination that you need to proceed with and gives us an idea about why the patient has presented and what could be the possible cause or the disease for which we need to manage. So a complete examination is the next step. Now, we ophthalmologists per se tend to ignore the systemic history and examination, but it is especially important since this name, the branch name itself, combines neurological medicine and ophthalmology. Thus, ophthalmological as well as systemic examination needs to be a part of our complete and thorough extensive examination. Now, it is difficult in OPDs to perform all the investigations for all the patients. Thus, once you reach a differential, you need to tailor the investigation such that in such resource limited settings, you are able to reach a diagnosis and localize the lesion, following which you need to manage the disease. Now, for the demographics, it is age and sex is extremely important because there are certain disorders which are common in a specific age group and a specific gender. Race and place is important because ethnicity helps us find a genetical variant that is more common, and place helps us find certain illnesses or infections that could be endemic in that area. Chief complaints, it is important that the patient complains in his or her own words. Unnecessary medical jargon leads to miscommunication, and in the era of Google, it leads to misdiagnosis. Patient needs to communicate and address their concerns in their own words, and no leading questions should be asked as far as the chief complaints are being talked about. Once you have talked about that, then you can probe into it with further questions depending on the illnesses or the chief complaints that they have and the priority in which they have mentioned it. For any symptom that they mention, it is important that you ask the onset, how severe the symptom is, lateralize the symptom, especially important in ophthalmology. Is it the right eye or the left eye or both? The duration, how long has it been? Because the more acute it is, the more aggressively you might need to investigate and manage the disorder. In neuro-ophthalmology, there could be an array of seemingly disjointed complaints, which is why it could be a considerable challenge to diagnose these disorders, which is why you need to form a coherent temporal profile of what happened and when, and what was the following investigation, what was the management. In neuro-ophthalmology, people take second or third opinions, so they come to you after taking certain treatment. So you need to jot that down. You need to make sure that the previous treatments, previous surgeries has been taken care of, so that it doesn't lead to misdiagnosis. Now, the first and the most important complaint is diminution of vision. You need to ask whether the vision is monocular or binocular. Since our patients present with field defects, they might put a field defect in the left area to be a problem in the left eye. So you need to probe, is it a defect or a problem in the vision in the left side of the field, or is it in the left eye? Because those lead to entails a different diagnosis altogether. Is it for the distance? Is it for the near? Is it associated with pain? If so, if the pain is associated with movement, if the pain is associated, that is sharp, it is transient, it is constant, it is associated with any diurnal variation. The diminution of vision could be constant or transient. Transient diminution of vision could be because of the amaurosis fugax, that could be a more sinister disorder underlying, like ipsilateral carotid disease. So that needs to be aggressively investigated. Papilledema can also cause transient visual obscurations, and even giant cell arteritis has been seen to have transient visual obscurations. So the onset of the disease, of the visual acuity diminution, should be looked into, because an acute or a sudden onset, as you can see, could be a traumatic cause, as we can evidently imagine, or it could be a vascular cause, which can be other ischemic disorder lead from diabetes, hypertension and other systemic diseases that predispose to it. Or it could be a subacute cause like inflammatory optic neuritis or an inflammatory cause, or it could be a gradual chronic progressive disorder which could be either because of a degenerative or a demyelinating disease or a compressive disorder. The diminution of vision could be progressive or static and can be associated with symptoms like visual distortions or metamorphopsia, which lead more to a diagnosis of a retinal disorder, photopsias or flashes, which could again be optic neuropathies or retinal disorders, and scotomas, which could be negative scotomas or positive scotomas. Positive scotomas or scintillations could be either a part of a very benign disorder like migraine or a sinister paraneoplastic syndrome. Now, diplopia is another important complaint in neuro-ophthalmological disorders, and from the slide itself you can see how disabling it could be for the patient, how disabling it is to see the slide for the next 5 minutes. So how disabling it would be for the patient. It could be monocular or binocular. This is the first question you ask because it leads to completely different sets of diseases which lead to monocular or binocular diplopia. Monocular diplopia is per se the problem in cornea or lens itself, and binocular is because of the abnormal visual alignment of the two eyes. Now, the diplopia could be worsening in a particular gaze and could be horizontal, vertical or oblique. This helps us give a clue about the nerves, the muscles that are involved in this, and thus per se the nerves that are involved in causing the diplopia, and thus help us localizing the lesion. You need to ask whether it is associated with neurological symptoms to find out whether it is a supranuclear, nuclear, intranuclear, because associated neurological symptoms is a usual finding in cases with diplopia. Periocular pain and headache might present to ophthalmological OPDs because the pain could be ocular or surrounding retroorbital or at periorbital, and it could be associated with movements or have variations during the day. You need to specifically ask for temporal headache or scalp tenderness because it could be a finding in the giant cell arteritis. The categorization of pain is important if it is severe, if it is unilateral, if it is throbbing associated with nausea or vomiting or aura like visual scintillations or fortification spectra, because it could be associated with migraine. Something that is constant or something that is intermittent, because it could be a special refractive, just normal refractive error or a cluster headache, or it could be as sinister as a subarachnoid hemorrhage if the patient describes it as one of the worst headaches of his life. Treatment history is important because drugs can cause an effect on the optic nerve. Anti-tubercular treatment is one of the most common treatments in our country, and drugs like ethambutol and even isoniazid and rifampicin cause optic neuropathies and thus could be an important finding in our history. Over-the-counter medication is a common thing in our country again, and these might contain steroids, and steroids and oral contraceptives are known to be one of the risk factors for IIH, the intracranial idiopathic hypertension, which is why it needs to be taken care of. Chronic hydroxychloroquine use and other chronic drugs should be asked for. Hospital admissions and surgeries are important because we need to know what has been done previously to make sure that we do not repeat the same mistake, or it could give us a different idea about what the previous diagnosis was, in which case they went ahead with the hospital admission. The surgeries, especially cardiac, could lead to a sudden decrease in BP and might predispose to posterior ischemic optic neuropathies. Systemic history, as we all know, is extremely important. Diabetes, hypertension and all the other the disorders which increase the coagulability are important because they lead to increased thrombotic phenomena, increased embolic phenomena, which could further lead to any ophthalmological findings. Now, the patient in our OPDs might say that their diabetes is cured or hypertension is cured, and thus they might not consider it an illness, but it is important to probe into it because a controlled diabetes is not equivalent to a cured diabetes. Systemic vasculitis is important because it may be associated with retinal vasculitis or giant cell arteritis. Malignancies are important because it could be a direct metastasis into the optic nerve, or it could be a paraneoplastic syndrome that could be present. In children, it is especially important to ask for perinatal birth as well as developmental history. Family history is important, especially for neurological disorders like multiple sclerosis and migraine, and ophthalmic disorders like the dominant optic atrophies and glaucoma. Level of education is important, and the use of drugs in relevant cases is important, especially chronic use, including tobacco, alcohol, recreational drug use and phosphodiesterase inhibitors. Now, coming on to the examination, we need to make sure that a complete examination of the visual function and an extensive examination of the lids and adnexa, anterior segment, posterior segment, as well as pupil is done. The visual function comprises of the color, contrast, the visual acuity, the depth perception, as well as the motion, which we check on fields. So, in anterior segment per se, there could be certain findings that could give us a clue of neurological diseases, which could include dilated corkscrew vessels, Kaiser-Fleischer rings, or Lisch nodules on the iris. Now, the visual function, we all know how to test it, but it is important to check the degree and the pattern of the visual acuity. And as sir says, we have burnt our fingers looking at a decreased diminution of vision and thinking of various possibilities, but a simple refraction a cycloplegic simple refraction can lead to a complete increase in the visual acuity, and thus a complete waste of time if you are going for all the investigations that were not required. So, media opacities and complete cycloplegic refraction should be first accounted for before going into a neuro-ophthalmological cause for the decrease in the visual acuity. Subtle losses can be checked by low contrast visual acuity, and for pediatric visual assessment, it is important that age appropriate visual assessment be done with Teller cards, Cardiff cards, Worth Ivory 4 test depending on the age of the child, and it requires patience. Visual function, another part as we discussed is stereo acuity, which includes distance stereo acuity like Frisbee-Davies distance test, or near test like the Randott test or the Titmus fly test or the TNO test. Other tests which were a favorite of the vivas of the previous professors, now hardly done, include the Wolfrich's phenomena as well as the photostress test. The optic nerve functions include a very important part of the neurological ophthalmological disorder, and thus should be done in a very organized and stepwise manner. It includes pupils, the examination of disc, color, contrast, visual fields, the electrophysiology and the imaging. The size, shape and the position of the pupil is something that should be looked for on the slit lamp. The size is important as it could give us an idea of the anisocoria. It could be a fixed dilated pupil. The shape could give us an idea of the previous surgery or any anterior segment dysgenesis, and the position also. Earlier there was an acronym called PERLA, which is the pupils are equal, round and reactive to light and accommodation, but it just does not put into perspective the lot of pupillary disorders that could still be there. The pupillary reflex is the first thing that needs to be checked when the patient comes to OPD, especially with complaints and history of diseases that could be signs of neuro-ophthalmological disorders. A bright light source like a halogen transilluminator or an indirect ophthalmoscope that we have should be used for checking the pupillary reflex. A distance fixation target to be given because near vision can lead to miosis. The direct pathway we all know, it leads from the first rods and cones to the bipolar cells to the ganglion cells, then through the retinal nerve fiber to the optic nerve head, and to the optic nerve decussating at the optic chiasma, then the optic tract, and the LGB, and the optic tract. Yeah, so the fibers here go to the pretectal nucleus, and from there to the Edinger-Westphal nucleus. The photos you see here are of German neurologists Ludwig Edinger and Karl Otto Westphal, and this then leads to a reflex, which is the efferent pathway, where you use the oculomotor nerve or the third nerve, and through the inferior division it leads to the fibers and constriction of the pupil. Now this constriction could be either well sustained or ill sustained and brisk or sluggish. You need to see it because it will give you an idea of the afferent and the efferent disorders, which needs to be separated and understood separately. A sluggish response could be either a demyelinating disorders or a complete hypoxic ischemic encephalopathy, and might give us an idea in children where nothing else is available to us except for a central reflex and pupillary reflex. RAPD is one of the most sensitive indicator and a hallmark of optic dysfunction, but one needs to know that it requires at least one normal pupil because it is a relative afferent pupillary defect. That means there should be an asymmetry in the disorder of the afferent pathway. It is also known as the Marcus Gunn pupil, but one needs to know that RAPD is not present in lesions above LGB because the pupillary reflex returns, the efferent pathway starts before that. Media opacities do not lead to RAPD, and malingering does not cause RAPD. Now, mostly RAPD is present in optic nerve disorders only, but a retinal disorder involving a large part of the retina, like a large, huge RD or a CRA or CRVO, can also lead to RAPD. Quantification of RAPD can be done with neutral density filters, which have increasing log units of 0.3, which are placed over the apparently normal eye, or it could be done with Bell's grading, where there is either, depending on the 5 stages, initial weak constriction and then a redilatation, or an immediate dilatation with prolonged illumination of the good eye. So this is the RAPD video that you see. So we need to see that once we put the light in the right eye, it is constricting. Separately, if you put light in the left eye, that also constricts. But if you do a swinging flashlight test and go from right to left, the left appears to be dilating. So this gives a relative afferent pupillary defect. Separately, the left does constrict to light, right does constrict to light, but the constriction in the left is lesser than that to right, which is why there is a relative dilatation when you go from the right eye to the left eye. In contrast to an afferent pupillary defect where the pupil does not react to light, does not constrict. In the pupil, it is important to differentiate between the sizes of the two pupil, where it could be a difference more than 2 mm is known as anisocoria. It could be physiological, present in around 17 to 18% of the population, or it could be pathological, which implies an efferent pathway dysfunction. A pupil that is worse in light, that is, it is not constricting, is a parasympathetic abnormality, and a pupil that is worse in dark, that is not dilating, is a sympathetic abnormality. Coming to the evaluation of the optic nerve head, few things that you need to see while looking at the optic nerve head is the color, the size and the shape, the margins, the cup per se, the neuroretinal rim, the vessels around the optic nerve head, as well as the peripapillary area. In the disc abnormalities, something that concerns us the most, there are 3 basic things that you should look for: congenital abnormalities, disc edema, as well as disc pallor. Congenital disc anomalies include a lot of disorders, including optic nerve hyperplasia, tilted discs, optic pit, optic disc colobomas, one which you see here in the right top, which is the morning glory disc anomaly, staphylomas, pseudoedema, and the one which you see on the lower right, the myelinated retinal nerve fibers. In disc edema, one should look at the following features to differentiate a disc edema from a pseudo disc edema. It should involve a swollen disc, an elevated optic nerve head, blurring of the margins, obscuration of the vessels arising from the optic nerve head, splinter hemorrhages, as well as venous engorgement. Now you see 2 cases here which could lead to a pseudo diagnosis of a disc edema, but they are not disc edema. The one you see on the right is the optic disc drusen, and the one you see on the left is a grade 4 hypertensive retinopathy because of malignant hypertension. As you can see, the cotton wool spots and the hemorrhages around it. There are a lot of causes of disc edema, which could be either unilateral or bilateral, which would be further discussed in the subsequent slides. Disc pallor and insult to the optic nerve leads to edema in the early stages and pallor in the late stages because of the axonal degeneration, which could be either anterograde or retrograde. But one needs to make sure that the disc pallor may not corroborate with the decrease in the visual acuity, and a mild temporal disc pallor could also be a normal finding and should not be aggressively investigated unless there are other associated symptoms. Primary optic atrophy could be a pathology that is proximal to the disc, and thus there is no secondary features that are available. It leads to a chalky white disc, sharp margins, demarcated cup and normal retinal vessels, or it could be a secondary optic atrophy with dirty grey disc, which contrasts to the primary optic atrophy, undefined, not well-defined margins, obliterated cup, and it could be either secondary to ischemia or papillitis, or there could, and on histopathology, there could be loss of nerve fibers, glasses of the ONH.
Yeah, I think these will be discussed in subsequent slides, so maybe just the findings, overall view would be better.
Yes, ma'am. So the extraocular movements we need to take care of, which could be unilateral, that is ductions, bilateral conjugate, that is versions, and bilateral disconjugate, that is convergence and divergence. Vestibular movements, pursuit, which are slow fixing movements, and saccades, which are quick refixation movements, should be looked for. Color vision is something that could be a very sensitive indicator, especially in the early diseases of optic neuropathies, and thus should be checked for. Even if you do not have sophisticated test, you can just give a bottle of atropine or something with a red head, and you can cap, and you can ask the patient to compare between the 2 eyes or compare between the 2 fields to find out if there is any color desaturation that is present. There are a lot of tests for color vision, which would include Ishihara test, Hardy-Rand Ritter charts, arrangement tests of Farnsworth-Munsell, which could be a bridge D15 version or a D100 version, Contrast sensitivity again with color is an early indicator of the optic neuropathies. In patients with diminished visual acuity, obviously this would be decreased, but in patients with a still maintained visual acuity, color and contrast can give us an idea of the decrease or early indicator of the optic neuropathies. Comparison between two eyes is important and could also be affected in macular disease and media opacities, including cataract. Could be done with Pelly-Robson charts, which are there in our OPDs, or Sloan charts. Visual fields. What is a visual field? A visual field is per se a space where amount of space which you look at when there is a constant fixation in a particular moment in a particular gaze. And what is a scotoma? Scotoma is a relative depression in that visual field surrounded by areas of a normal field. In optic neuropathies per se, there could be either a generalized constriction, central defects, or nerve fiber bundle defects. Confrontation visual fields should be a part of every afferent system examination, because although it is not that sophisticated as the other static perimetries, but in OPD itself it could give you an idea of the visual field defect, and a very flexible form of visual field, and if done properly and skilled, it can provide information equivalent to a Goldman or a Humphreys chart. A simple Amsler grid in an OPD could also give you an idea of the scotomas that could be present. We all know the visual pathway. Simply putting, it is from the retina to the optic nerve, decussating at the chiasma. Only the nasal fibers decussate at the chiasma, not the temporal fibers. Nasal fibers meaning temporal field. And then they go into the LGB, the lateral geniculate body, Mayer's lobe, which is the inferior temporal lobe, and the parietal lobe, and then finally to the calcarine occipital cortex. It is important to understand the arrangement of fibers on the optic nerve, as it can give us an idea about the visual field effects. Basically, our fibers are arranged primarily as the papillomacular bundle, which forms the 90% of the fibers, the superior arcuate fibers which come from the nasal and the temporal side, and the inferior arcuate fibers which come from the nasal and temporal side inferiorly to the optic nerve head. And depending on which fibers are involved, you will get a particular visual field effect, and thus the visual field per se can help us in the localization. Visual field also helps us in monitoring or progression of the disorder, because in cases with decrease or in visual field, you can find out, like in IIH, if there is a particular decrease in visual field, there is an increase in the optic neuropathy. Now, if the PMB is involved, there could be a central or a centrocecal scotoma. If there is a nasal fibers that are involved, it would lead to a temporal wedge-shaped defect, an enlargement of the blind spot, sedal scotoma, a nasal step which is respects the horizontal midline, an arcuate defect depending on how much of the arcuate bundle is involved, and the altitudinal defect which almost touches the other horizontal midline. This is the arrangement of the fibers that is present in the optic nerve head, and these fibers originate from the blind spot that is present and then further lead to the optic nerve. A centrocecal scotoma can be present in optic neuritis, toxic optic neuropathy, especially ethambutol, and dominant optic atrophies like LHON. Other disorders apart from neuro-ophthalmological disorders could also lead to optic nerve defects, and it is important that you rule out retinal as well as glaucoma per se, because sometimes the advanced or glaucomatous cupping could lead to a diagnosis of disc pallor. So these are important to be investigated. And there is another thing, there could be a coexistence of glaucoma as well as neuro-ophthalmological disorders, so it needs to be investigated properly. Lesions anterior to the chiasma, there could be lesions anterior to the chiasma and the lesions posterior to the chiasma. The lesions anterior to the chiasma will only involve one eye, because the fibers have not decussated yet. So it is unilateral and there is a loss of visual acuity, so there will be unequal vision in both the eyes. And since it is involving the optic nerve, there would be an afferent pupillary defect, and the importance of such is that there could be an evidence of this on the optic nerve head, that is, that could be a disc pallor which could give an idea or the evidence of lesions that are anterior to the chiasma. This is the arrangement of fibers in the chiasma. When it leaves, the macula is occupying a large part in the temporal area, and further when it reaches the chiasma, this is the particular arrangement. It is important to understand this. It is of paramount importance to understand this, because lesions, compressive lesions, might affect a certain part of this and thus lead to a certain visual field effect, as we will see further. The chiasmal relations, lesion could be central, prefix, that is anterior, and postfix, that is posterior to the chiasma. It is important to understand this because anteriorly there is a von Willebrand's knee. This is the inferonasal fibers of the which go around, take a small U-turn and then decussate. The importance of this will be discussed further. And posteriorly there are fibers that are running high and posteriorly, which are the superonasal fibers, and the posterior most fibers, which are the macular fibers. And this is important because it can be related to the supraoptic recess. Now at the first go, what you will see this is that there is a bitemporal hemianopia. But no, this is not the case. It is important that the visual fields are arranged such that the left is in the left side and the right is in the right side. This is not a bitemporal hemianopia, this is a binasal hemianopia, just put in reverse. You can see the visual, the blind spot, that is of the right eye, so this comes here, and this is of the left eye, and that goes there, so it's a binasal hemianopia. This is not a chiasmal lesion. Chiasmal lesions, this is an actual bitemporal hemianopia and could be seen in pituitary adenomas, craniopharyngioma, meningiomas, optic gliomas, and ICA aneurysms. The optic tract, here for the first time it represents not one eye but one half of the binocular visual field, and which includes the temporal fibers of the same eye or the ipsilateral eye and the nasal fibers from the contralateral eye. That is the nasal representation or the nasal visual field of one eye and the temporal of the another. Lateral geniculate body receives the ipsilateral fibers in the areas 2, 3 and 5, and the contralateral in the 1, 4 and 6. Retrochiasmal lesions are important because field defect becomes more and more congruous and homonymous as you go posteriorly, and posterior to the LGB there is no involvement of the pupil. As I was discussing earlier, this is a junctional scotoma. It is very characteristic and one of the most diseases with the most characteristic visual field defect, as it leads to a superotemporal visual field defect in one eye, which is involving the knee of von Willebrand. These are inferonasal fibers, so it would involve the superotemporal of the other eye. This also puts into perspective that when there is a diminished vision in one eye, it is important to get the visual fields of the contralateral eye, since it can give us an idea of the disease that is happening, the pathology that is happening, and prevent the further problem that could happen in the other eye as well. Optic radiations travel in the retrolenticular part of the internal capsule, and the fibers that exit from the LGB rotate by 90 degrees again to regain their original arrangement. Thus, the superior fibers in the upper part of the radiation are present inferior, and inferior part are present inferiorly. They commence from the anterolateral part of the LGB and sweep anteriorly and then laterally along the temporal horn of the lateral ventricle to form the Mayer's loop, and extend below posteriorly to form the posterior radiations and then end into the occipital cortex. As we saw earlier, they are more congruous and it could be associated with other clinical signs or systemic signs that are present. Now, it is important to realize that one field per se should not give you an idea of the eye. The visual field of one eye should not let you give an idea of a visual field defect. This is, one would think this is a quadrantopia, but it is important that you look at the field of the other eye, because this is just a scar that is present. It is not a quadrantopia, A, because it is not present in the visual field of the other eye, and B, because it is not respecting the vertical meridian, although it is not always necessary that it is exactly at the vertical meridian. This is an actual quadrantopia and could be, it involves a contralateral, homonymous, superior quadrantopia or a superior field defect, which could be present in glioma, metastasis, ACA infarction, trauma, demyelination and abscess. This is involving the parietal lobe. It could be in hemorrhages, AV malformations and tumors. Occipital cortex, the superior fibers are present in the superior to the calcarine fissure, where the inferior fibers are projected inferior. In each eye, there is an isolated crescent where there is no overlapping point in the other eye. This temporal crescent perceived by the nasal retina is represented in the anterior most part of the calcarine cortex. The occipital cortex, this is a field of the right PCA infarction with right temporal and occipital lobe ischemia, leading to a complete homonymous hemianopia. As you can see, it is splitting the macula. Depending on the involvement of the vessel, it could be either macular splitting or macular sparing. Along with the visual fields and the ophthalmological examination, last but not the least, one should make sure that cranial nerve examination is done, because there are lesions in the midbrain and pons that include a nucleus of the 5th, 7th and the 8th nerve along with the cranial, along with the oculomotor nerves. So it is a small test like a corneal or a facial sensation can give us an idea of the 5th nerve. Angle of the mouth, as you can see, can give us an idea of the 7th nerve palsy, and 8th nerve, just asking for hearing defects or looking at the gait can idea of the 8th nerve also. Thank you.
Thank you, Dr. Yashwara. That was a very comprehensive detailing of the most important part of neuro-ophthalmology practice. spending time with the patient, listening to the history, and doing a detailed clinical examination. And I say, fortunately or otherwise, we do not have access to too many of the newfangled investigations that other subspecialties have. So we make use of the latest, the most upgradable gadget that we all can carry with us, which is between our ears. So if we keep up here is going to tell us about the role of OCT in neuro-ophthalmology.
Good morning, everyone. So I'll be discussing a fancy instrument that Sir said we don't have, but we do have one that is called OCT. So OCT, as you all know, has been used for a very long time for retinal diseases and glaucoma, but right now we've also started using it for neuro-ophthalmological conditions. Basically, we are using two main examinations. One is of the peripapillary retinal nerve fiber layer, and one is of the GCIPL, which is the macular evaluation. So basically, in a peripapillary retinal nerve fiber layer evaluation, we make a circle which is centered on the optic nerve head with a diameter of 3.4 millimeters, and we examine the thickness and compare it with the normative data that the machine has. Normally, it is about 105 microns with an estimated physiological loss occurring at 0.017% per year. This is what a printout of an RNF and OCT looks like. For easy comparison, we can see that it is color-coded. The green color will show that the area is within normal limits in thickness. The yellow area shows that it is within borderline limits, and the red area shows that it is definitely outside the normal limits of thickness. Then moving on to the macular evaluation. After segmentation, it evaluates the macular thickness as well. It has two basic parameters that we get. One is GCC, which includes the nerve fiber layer, ganglion cell layer, and the inner plexiform layer. And it also has another parameter, which is called the GCL-IPL, in which it subtracts the nerve fiber layer and gives the thickness of the GCL plus the inner plexiform layer. So what we have seen is that a strong relationship with visual loss and the visual field sensitivity is seen in patients in which we do the GCL-IPL thickness measurement. It also shows the evaluation of neuronal loss occurring in the presence of optic disc edema, which I'll be discussing subsequently. So this is what the map looks like. It uses the ETDRS 3 circles and shows the parameters within the 1 millimeter, 3 millimeter, and 6 millimeter circles. It shows the volume in that area, and it also shows the thickness in that area. And as we can see that the warmer colors are used for higher thickness, and the cooler colors are used for where there is thinning. So this will give us a gross idea without having even very much knowledge about the thickness in that area, whether there is some gross thinning occurring in that area, where the warmer colors will turn into the cooler colors, as we will see in subsequent slides. So where are we using OCT in neuro-ophthalmology today? One is in multiple sclerosis and demyelinating conditions. Another use is in optic disc drusen patients, in ischemic optic neuropathies, in papilledema, and other miscellaneous uses like compressive optic neuropathy, LHON, and toxic optic neuropathy. As we see that in most of the multiple sclerosis patients, optic neuritis is often the first manifestation. So what we see is that even after optic neuritis has gone away, patients complain that they are having an incomplete visual recovery. And what we saw in patients when we did the RNFL OCT, that when there was an extensive RNFL loss within the first 3 to 6 months, the patients did not get back their complete visual function. So here comes our first use of OCT in neuro-ophthalmology, that it will help to detect that there is RNFL thinning occurring, and we can predict that patient will probably not have a complete visual recovery after the disease goes away. Another thing that we can think of is that regenerative strategies can be initiated within the first 6 months period of the acute event before the thinning actually takes place. Another thing that we have noticed is that in patients of multiple sclerosis, there is also a subclinical RNFL loss occurring, as there is an insidious atrophy of retinal nerve fiber layers. What this means is that patients who have never even had an acute episode of optic neuritis also are noted to have a subclinical RNFL loss. One more thing that we check in these patients is the macular volume, which is also decreased as corroborating with the temporal RNFL layer. For patients of multiple sclerosis, for monitoring, one line change in contrast, basically low contrast letter acuity score is considered to be optimal for monitoring the visual function of patients of multiple sclerosis. But what happens is that it is a very subjective score. So we could have an objective modality to compare how the patient is progressing in these patients. So what we can do is that we can compare the RNFL OCT at different time points, and we can show that the patient is either stable or he is further progressing in optic neuritis. Another use is upcoming is in other patients of neurodegeneration, because a decrease in RNFL has also been shown in these patients as compared to the age-matched controls. But however, it is still an upcoming modality, so we don't have the normal data for these patients, how it progresses and how they will respond to treatment. So it may be possible in future to use OCT to measure the RNFL thickness as surrogate markers for axonal loss occurring in neurological diseases. We have published data from our own center as well, in which we have found that the RNFL thickness was significantly reduced in optic neuritis and multiple sclerosis patients, and it corroborated very well with the magnitude of visual impairment and other visual parameters. Pillai et al. In their study from our center also showed that the GCL and IPL thickness is even more sensitive than RNFL in early MS with or without optic neuritis. So this was a patient, 37-year-old male with a history of relapsing remitting multiple sclerosis. He came to our OPD for normal visual examination. He had no history of optic neuritis. The vision was 6/6. But as you can see on the RNFL OCT, he has already started developing thinning in the temporal areas. And when you look at the macular ganglion cell layer complex, as I was discussing, that the red area is now turning into the cooler colors of blue and gray, showing that he has already developed thinning in the macular ganglion cell layer. The second important modality, important use of OCT is in patients of optic nerve drusense. So when we see a glowing hyaline body on ophthalmoscopy overlying the optic nerve head, then the diagnosis is very clear. But when it is buried, then OCT can also come to our rescue in addition to an ultrasonography or an autofluorescence. These are some of the differences which we have found on OCT between optic nerve head drusense versus a true disc edema. Firstly, we can directly see the hyperreflective mass under the peripapillary retina, especially in the nasal area. This was seen because in the normal course of optic nerve head drusen progression, these masses usually form in the nasal quadrant of the optic nerve head, and that leads to displacement of the nerve fibers in the other quadrants. Eventually, since its presence for a very long time, it leads to compression of the underlying nerve fibers and they start to undergo atrophy. So the characteristic presentation on OCT that we see is that it is thinner in the nasal area and thicker in the temporal areas, with a negative correlation with the height of drusen and the nasal RNFL thickness. Another thing that we frequently see is that this internal contour is very smooth in patients of optic nerve head edema, of disc edema, and in cases of optic nerve head drusen, it gets a very lumpy, bumpy contour. So this is what I was talking about, that a hyperreflective body can be seen in patients of optic nerve head drusen, but in cases of true disc edema, as we can see, just a hyporeflective area is seen underneath the peripapillary retinal nerve fiber layer. This is the lumpy, bumpy contour that has been described in patients of optic nerve head drusen, as we can compare it with the lazy V appearance that is seen in patients of true disc edema. Another sign that has been described by Lee et al. Is that at the junction of the optic nerve head drusen, the outer plexiform layer and the RP epithelium appear to diverge. And as we can see in this image, there is a boot-shaped area which is observed adjacent to the optic nerve head. So these are some of the ways in which we can differentiate on the basis of OCT whether it is an optic nerve head drusen or it is a true disc edema. Moving from pseudopapilledema to true papilledema, the question which normally comes to our mind is that why do we even need OCT? Because in patients of papilledema, we can do a good fundus photography, and a good ophthalmological examination is good enough to monitor the course of the disease of the patient. But then there are certain fallacies. Firstly, there can be a different inter-observer agreement on the grading and severity of papilledema. So what will happen is that if a patient comes to one clinician and then goes to follow up with another clinician, they may not have the same agreement on the degree and severity of papilledema, which can change the management of the patient. Another thing is that not in all cases it is very easy to distinguish between pseudopapilledema and papilledema. Another thing is that as the disc edema decreases, it can be due to two causes. One is that the patient is responding to our treatment. The other possibility could be is that the RNFL is undergoing thinning and it is going into the atrophic phase of papilledema. So to differentiate between the two, OCT comes to our rescue. For the monitoring of these patients, we have a Frisson scale. However, it is a non-continuous scale which has 6 values. So maybe if we use a continuous grading system, it would probably help us in better objectively quantifying the disease. So this is what has been described in OCT, that how will you differentiate between pseudopapilledema versus papilledema. Basically, in papilledema, there is a pressure differential between the retrobulbar optic nerve and the vitreous cavity. So what this leads to is that there is a deformation of the Bruch's membrane surrounding the neural canal. As you can see, there is a change in the contour of the Bruch's membrane. So this is characteristically seen in patients of papilledema and can help us in differentiating from pseudopapilledema. Another thing it tells us is that the degree of angling towards the vitreous will help in monitoring the force differential over time as the intracranial pressure changes, and that can help us guide that the patient is responding to treatment as the angling, the acuteness of the angle will decrease over time. The volume and the surface characteristics has been used to develop a 3D segmentation approach to determine the volume and the thickness as a continuous alternative. So now you can easily use it for determining small changes over time in patients being treated with papilledema, which are being followed up over a long period of time. The third thing which I was talking about is that patients subsequently start developing retinal fiber layer atrophy. So what you can do in these patients is that even if the RNFL thickness seems to be decreasing, you can combine it with macular ganglion cell layer thickness. So what you will get is that if there is a successful treatment and the neuroaxonal structure is being preserved, in addition to the reduction in peripapillary RNFL thickness, the macular ganglion cell thickness will be preserved. However, if there is a treatment failure and the patient is worsening, in addition to the reduction in RNFL thickness, the GC-IPL thickness will also be decreasing. That will tell you whether the patient is worsening or he is responding to treatment. So this was a patient of IAH with papilledema. As you can see, in addition to the disc edema, you can see that there is the GC-IPL thickness is within normal limits. This was another patient, 30-year-old female with history of IAH with visual acuity 6-9 parts. As you can see that RNFL is completely thickened in these areas. But when we did GC-IPL thickness in maps in these patients, as you can see that the GC-IPL thickness has already started showing thinning. So these are the patients which even when the RNFL thickness will start decreasing will show that the GC-IPL thickness is worsening. So you can tell that the patient is not really responding to treatment. This GC-IPL thickness worsening would tell us that the patient is probably going into a chronic atrophy phase. So basically this will tell us what the RNFL thinning demonstrates. If the RNFL thins out, but this remains constant, patient is responding. If this thins out, but this continues to worsen, that would indicate that the patient is having RNFL atrophy. Next, we come to ischemic optic neuropathies. The thinning of GC-IPL has been shown to occur much earlier than the RNFL thinning. Also, it will help us in longitudinal assessment and using it as a monitoring tool in these patients. As you can see, this is a patient of NAION. In the acute stage, the optic nerve head is showing swelling. In the bottom row, we can see that 2 months after the acute episode, the disc has developed pallor along with a superior RNFL quadrant thinning. Importantly, we see patients of toxic optic neuropathy, which is basically seen in patients who are on ATT. So what we can do in patients of ATT is that we can get a baseline OCT and we can look for changes on subsequent follow-up, which will tell us that the patient is having a response to the ethambutol toxicity. Moreover, we have also seen by Lee et al. That the GC-IPL thickness and the amount of temporal GC-IPL loss during the first 6 months has been negatively associated with the amount of visual recovery that occurs at 12 months in patients of ethambutol toxicity. So this was a patient, a 37-year-old male on ATT for 6 months. Vision was 636 in both the eyes and color and contrast was also diminished. So we looked at the RNFL OCT and we saw that there was thinning in the RNFL OCT on the temporal papillomacular bundle area. And then we did the macular ganglion cell layer analysis and we saw that there was a significant thinning occurring. So these patients are the ones which will not probably respond completely after stopping ethambutol, and they will have persistent visual field defects. LHON is another pathology where we can use it as it shows a temporal correlation. Initially, the temporal fibers get affected and eventually all the other fibers get affected. So basically, this is how it progresses. It starts from the temporal area where the first thinning starts occurring and eventually it goes on to involve all the other quadrants. The main role that it can have in future in LHON is that you can detect which patients are in the evolving stage of the disease, and when the patient is progressing in RNFL OCT thinning, that is the window where we can use drugs like ibibenone and chloroquinone and COQ to treat these patients. So we have also new upcoming advances, like we have OCT-A, which is coming up, which is displaying finer vascular details of the optic nerve head. Studies are underway, and a study has from our center has shown that there is significant reduction in the peripapillary retinal vascularity in patients of NAION. As we can see in these photographs, that in the healthy eye, we can see the vascularity of the superficial retina, but in the same patient with, in the eye which has developed NAION, we can see these dark areas which reflect the lack of perfusion in the superior and temporal quadrant. This is another finding which has been demonstrated in our center only, where we have seen that there are some vascular tortuosity seen in patients of LHON in the early phase of the disease. As we can see in the nasal and the temporal retina, there are some tortuous vessels which are visible in this patient of LHON. To conclude, I would like to say that the scope of OCT in neuro-ophthalmology continues to expand. It can be a valuable aid in the diagnosis and monitoring. However, we must remember that it is a computer-generated information, and it should always be reviewed for potential inaccuracies and artifacts and correctly be interpreted in the clinical context. Thank you.
Thank you, Dr. Asmita, for an excellent coverage over the newer and emerging role of OCT. I'll ask Dr. Parag to talk about electrophysiology, which is another sheet anchor investigation in neuro-ophthalmology. Any questions in the meantime? We could take a couple while the presentations are being set up. Yes, Dr. Amrita.
What fields are ordered, what fields are ordered for neuro-ophthalmology examination?
So, some time ago, we used to have the Goldman perimetry, which was very useful. Unfortunately, that is not available easily. Even in our center, we kind of struggle because it's a very manpower-intensive investigation. Essentially, if you're looking at, so you have two kinds of gross field options available. One would be a screening field, which would be a 120-point screen, and other is the routine 30-2 that we do. Most of the neuro-ophthalmological investigations can be picked up and followed up with a 30-2 investigation, and it suffices for almost, I would say, most of the conditions. In some conditions where the patient is unable to sit through even these now pretty rapidly done thresholding algorithms, you could do a 120-point screen, especially if you have patients of, say, neurological issues who are unable to sit that long, or you want to look for the peripheral field effect. The important thing to remember is that this is not like glaucoma, where actual thresholding is very important. Most of neuro-ophthalmological disorders are like an all or none phenomena. So if you are looking for bitemporal hemianopias, you are virtually having significant field effects that can easily be picked up even on a screening field. So if you have a 30-2 which you are not able to explain with your clinical features, or you feel that it's coming clean and normal, but there are peripheral changes which were expected in them, like in a patient of IIH or thinking of constricted fields, then you can do a 120-point screen. So these would be the options I would look for. If you're looking for specifically for early toxicity, ethambutol, LH1, then sometimes you may do a 10-2 to pick up small field effects which are not coming up properly in a 30-2, but yet the patient is having subnormal vision. So that's the condition where you may actually want to do a more finer field of the macula. But again, like I said, those are fairly uncommon. We have, by the time patient presents, they usually have fairly well-developed field which can be picked up by a screening field. Thank you. Yeah, I think we'll be. So again, LHON is something that would present, by the time it comes to you, usually would be having a fairly significant field effect. If you are looking for, so currently again, OCT, while it is telling us a fair amount of information in a large variety of investigations, it's still not something that is being used to decide interventions or adequately giving us information. So OCT is already affected usually by the time the patient comes to us. You can follow up the patient clinically and see for change in visual functions. However, if the visual functions are not changing significantly and you want to follow up on OCT and see how it changes, I would say at least 3 months would be a gap for you to actually see for any significant change, because of the least count between or the variability of an OCT machine itself. That itself may not give us enough unless we are having a significant follow-up. But still, like I said, OCT is still evolving in its role. It's being used a lot aggressively for neurological conditions also, like Alzheimer's, Parkinson's, but again, its exact role is still yet to be appropriately defined. Yeah, I think we'll take one last question before we move on. Yeah.
Actually, nowadays, cataract is more common. So, is it possible to do this kind of OCT for removal or the cataract or looking less quality?
I'm sorry, I didn't quite get its relation to cataract.
Actually, I said that nowadays there is a common of cataract in all the patient, not in even in old patient, even in young patient also. So, is it helpful in to OCD or something like that?
To pick up for fundus changes or to prognosticate a patient for outcomes after cataract surgery.
Yeah.
So it's a little difficult to say because the quality of the image also deteriorates very rapidly if you have a significant media opacity. So your predictability or your reliability of the instrument would be less. I would still say that a clinical assessment would be far more important. But yes, if you are suspecting that there are some changes, you may do an OCT and combine it with your other clinical examination to prognosticate the patient. Of course, if it's coming definitely thinned out, then yes, the prognosis does become poor, especially if you can, you can associate it with the disease. So probably you're meaning that in presence of a neuro-ophthalmological condition and the patient has cataract. I would say anyway that in a patient who has a baseline cause for subnormal vision and develops even a moderate or early cataract, I would say you should go in early and do a cataract surgery. The outcomes of cataract surgery are now so good, and the media opacity will add to the poorer quality of vision in that patient. So I think we should give them the best possible vision. Post-cataract surgery, their assessment of visual fields, OCT, all these things will also improve so that we'll be able to know their prognosis and long-term outcomes. So from the other side, I would say it's probably better to go in early and yeah.
One question I also have. Glaucoma is also common nowadays. So on that case, what we can do? In the patient, in the early age patient that is 16 to 17 years old, then what will we do?
No, I'm not quite clear what the question was. I mean, like how?
I asked that glaucoma.
Yeah.
Glaucoma is nowadays a common disease. So I would say most of the time, the 17 to 18 years child also have such kind of disease,
So
glaucoma.
open angle glaucoma is not all that common. I would say you need to do a very detailed workup if you are suspecting glaucoma. And while I always maintain glaucoma is actually a neuro-ophthalmological disease,
Sir,
I think we'll discuss glaucoma subsequently. We'll maybe go on and when we do case discussions, maybe we'll take up specific cases and discuss that. Okay, I will go on.
Thank you.
Okay, thank you.
A very good morning to all of you. My name is Dr. Parag. I will be presenting electrophysiology, investigations relevant to neuro-ophthalmology. Starting with introduction, electrophysiology is an assessment of electrical potential which is obtained by visual stimulation. It is helpful in assessment of integrity of road cone system and visual pathway. Commonly used electrophysiological investigations in ophthalmology are electroretinography, ERG, electrooculography, EOG, and visual evoked potential. From neuro-ophthalmology point of view, electroretinography and visual evoked potential are more important. EOG is more used in retina clinic for best retinopathies. Starting with visual evoked potential, it is a record of gross electrical signal which is generated at visual/occipital cortex in response to visual stimulation. It is an objective test which is non-invasive, and it is a quantitative measure of functional integrity of entire visual pathway from retina to visual cortex, but it is non-localizing. Now the types of visual evoked potential or response. So most of the time pattern VP or VER is indicated in all clinical scenarios. Wherever pattern VER is not possible, we opt for a flash VER, like in cases of dense vitreous hemorrhage, media haze, and non-cooperative patients like infants. Both of them differ in the type of stimulus which is presented. In pattern VER, a checkerboard stimulus is presented. In flash VER, a diffuse flashing light stimulus is presented. And while interpreting pattern VER gives us a sense of form sense and thus give us a rough estimate of visual acuity, flash VER just gives us an indication of whether the light is being perceived by the cortex, and it just gives us an idea of the integrity of the visual pathway. So this is the stimulus which is usually presented in flash and pattern VEP. So this is the diagrammatic setup of diagrammatic representation of the setup. One is the visual stimuli here in the figure, which is the checkerboard, and the scalp electrodes are used to record the electrical potentials. There are 3 electrodes which are one is active, other is reference, and third is the ground electrode. The electrical signals which are generated are amplified using an amplifier, and thus there is a computer readout system where we get a printout of the electrical potentials. So this is a normal VEP with a normal latency and amplitude. In a flash VEP, we get negative waves and positive waves. This is basically a waveform. N mainly denotes a negative wave and P denotes a positive wave. So N1 P1 means the first negative wave and P1 means the first positive wave. So latency is defined as the time taken from the onset of stimulus to the positive peak at P2, and in normal population it should be less than 125 millisecond. In amplitude is measured from the negative peak of N2 to the positive peak of P2, which is approximately equal to 10 or more in general normal population. This graph shows us a VER with reduced amplitude and delayed latency. As we can see, the distance between N2 and P2 has reduced, which is the amplitude in microvolt, and the latency has been prolonged beyond 125 milliseconds. Now, pattern reversal waveforms are slightly different from the flash VERs. Here we get 3 waveforms, one negative peak at 75 millisecond, which is defined as N75, which is the normal nomenclature, positive peak at 100 millisecond, which we call as P100, and a third wave negative peak, which is N135. So with arrows we can see from N75 to P100 is the amplitude, and from onset of stimulus to the onset of first positive peak is the latency. Now we'll look at different pathological conditions and variations in VER in each one of them. In optic neuritis, as we can see, usually the preferred technique is the pattern VER, but as I say, in cases where pattern VER is not possible, we opt for a flash VER. Like in cases of, if there is a profound vision loss in atypical optic neuritis, then we may opt for a flash VER. So this right eye shows the normal VER, and the left eye shows that there is a decrease in the amplitude as well as a delay in the latency. So in optic neuritis, amplitude usually recovers after the acute attack of optic neuritis subsides, while the latency does not recover. In optic neuritis which are associated with demyelinating conditions, most commonly multiple sclerosis, even in 90% cases of multiple sclerosis without even an history of attack of optic neuritis, we do see a prolonged latency, which may suggest a previous attack of optic neuritis. In ischemic optic neuropathies, we do not see a prolongation of latency, but we do see a sharp decline in the amplitude, as we can see in the VER. So the amplitude has reduced. In traumatic optic neuropathies, pattern cannot be done because the injury to the optic nerve is significant, and thus we don't get any of the waves which we see normally. So points to remember is, if we are considering visual acuity under evaluation, amplitude is more important. For suspected lesions in visual pathway, latency is more important, and presence of isolated decrease in amplitude is non-specific and is to be considered significant on serial evaluations. And VEP is symmetrical for both eyes usually, and asymmetry is more suggestive of a pathology. So delayed latency is more seen in demyelinating optic neuritis, glaucoma, aging, and uncorrected refractive errors, while delayed amplitude is more suggestive of a optic neuropathy or toxic or compressive optic neuropathy, along with amblyopia and uncorrected refractive errors. So in compressive optic neuropathy, we see decline in both latency as well as prolongation of the decline in the amplitude and prolongation of the latency. So next, coming to electroretinogram. Here the electric potential generated in response to the light stimulus from within the retina are recorded. So it is a mass electrical response with no localizing value. So in in ERG, the amplitude which is generated is directly proportional to the amount of retina which is stimulated. Most of the indications are for retinal pathologies like retinal pigmentosa, congenital stationary night blindness, Stargardt's, and drug toxicities. Typical ERG waveforms consist of A wave, which is due to hyperpolarization of the photoreceptors, including rods and cones. B wave is due to depolarization of the bipolar cells, and oscillatory potentials are due to they are amplified potentials generated from the amacrine cells. So in a typical ERG form, there is no separate characterization for rods and cones. For to separate interpretation of rods and cones, we do ERG in scotopic conditions as well as photopic conditions. For this, ISCEV is the International Society for Clinical Electrophysiology and for Vision. They have given recommendations and protocols for doing ERG in photopic as well as scotopic conditions. So this is a normal, this graph which we see here. Initial first three graphs which we see are in dark adapted state, which give us a rough idea of the function of the rods, and the lower ones are done in the light adapted state, which give us a function of the cones. So in retinal pathologies where the cone is affected, like cone dystrophy, we will see abnormalities in this part of the graph, and in retinitis pigmentosa and congenital stationary night blindness, we might see abnormalities or deviation from normal in these graphs. So these are some of the electrodes which are used for setting up and doing a electrophysiological examination. Some are contact lens based, which function along with the contact lens, and they come in direct contact with the eye surface cornea. And this Burian Allen electrode is the contact lens based. Jet electrode is also a contact lens based, and Dawson trick electrode is the one which comes in contact with the bulbar conjunctiva, and this gold cup is a reference electrode. Next is the pattern ERG. Pattern ERG was first recorded by Riggs. Pattern ERG is primarily used to differentiate between optic nerve disorders and macular disorders. Indications for doing pattern ERG are optic neuropathies and ocular hypertension oblique glaucoma. So normal waveform in a pattern ERG shows two negative waves and one positive wave. First negative wave, which comes at 35 milliseconds, is termed as N95, and first positive is P50 and second negative is N95. So basically the second negative wave which comes at 95 millisecond is supposed to come from ganglion cells and the first two waves are coming from the retina. So isolated difference in one of the waves can give us a clue and help us in localizing where the pathology is. So selective affection of N95 component with near normal P50, it points towards an optic nerve pathology, and N95 to P50 ratio remains unaltered in macular cases and it decreases in optic nerve disorders, and this ratio is more significant than isolated values of N95. Now lastly, coming to the multifocal ERG. Multifocal ERG, it stimulates various focal areas of the retina at the same time and picks up focal disease as well as maps the disease distribution. So indications for multifocal ERG are central or paracentral maculopathies and drug-related toxicities. In this is a waveform showing a single multifocal ERG where there are two negative waves and one positive waves. It is done in photopic conditions and this is a cone-driven response. So this is the kind of graph which we'll get for a multifocal ERG in a normal patient. So there are three components in it. First is the traces of multifocal ERG, which are the different eccentric readings of the ERG at equidistance from the fovea. So this is a trace diagram, and in second image what we see is the ring averages. What exactly it is, if we consider fovea as a center and draw concentric rings, within the rings, whatever the average readings are there, they have been plotted in the average has been calculated and plotted and shown in the image B. So for example, in this first one is at the level of the fovea, and as we move down to second, third, fourth, fifth, we are going away from the fovea in concentric rings. So it gives us a estimate of, it helps us in localizing the area of the disease. And the third one is the 3D response density tomography. It gives us the overall signal strength in a per unit area. Thank you.
Thank you, Dr. Parag. Very nicely talked about the key components of electrophysiology. I'll request Dr. Monica to start her talk on radiology in neuro-ophthalmology, the key aspect. Any questions I think we'll take later, but I think we'll take it after this so that we can put all the investigations together. But just showing that all these investigations are directed only when suspected. When you come to a fork in the road where you want to take left or right, only then you take a call as to what I need to do. So when there is a doubt, you take use of these investigations. If there is a significantly affected visual function and you know that there is an obvious pathology, the VP or electrophysiology really does not help you too much. Like the multifocal ERG are extensive uses in conditions when we know that there is a temporal pallor and we are not still able to see any cause neurologically, and the fovea also grossly looks normal or the anatomical contour looks normal. So you could do a multifocal ERG followed by a multifocal ERG to see for small subtle foveal changes which are responsible for the subnormal vision but are not being easily picked up because of the anatomical changes are still not there. So every investigation has a place. So if you have a patient who is not seeing and there is no obvious pathology, you can do a visual evoked response to see for the structural integrity of the visual pathway. So each investigation has a role, and every investigation should answer a question. It shouldn't be done just because we are supposed to do an electrophysiology in neuro-ophthalmological conditions. It has to add to our understanding and help us to take a decision about diagnosis, management or prognosis. So we now go to the most important part of investigations in neuro-ophthalmology, the radiological component, and Dr. Monica will be talking about it with some very interesting cases. Dr. Monica, please.
Thank you, sir. So after an exhaustive session talking just about eye, I'm going to take you all to a very different department altogether, which is radiology, however still linked to neuro-ophthalmology. So neuro-ophthalmology, as we all know, is a branch which examines the relationship between the central and the peripheral nervous system along with eye. So neuroimaging complements the diagnostic process in this branch, and it also helps to prognosticate certain conditions. However, The most important thing is that the bedrock of clinical localization still remains a very focused history and thorough examination, as Dr. Aishwarya has already spoken about it earlier. Because if we kind of obviate this thing and we over-rely on the neuroimaging process, then we can end up having a lot of diagnostic dilemmas, and that can be coupled with imaging of a wrong place with the right test, or imaging of a right place with the wrong test. So what points do we need to think before ordering any neuroimaging is that what are the potential mechanisms which are explaining the patient's condition, and what all are the urgent mechanisms that definitely needs to be ruled out. So for example, if a patient presents to you with a lateral rectus palsy, acute onset, in a young patient, you would think of causes, maybe it could be a viral infection, it could be parainfectious, or it could be some space occupying lesion. So a space occupying lesion obviously is an urgent mechanism that definitely needs to be ruled out. So after we have ruled out those mechanisms, we need to think upon additional imaging features which can give us an idea as to what we are dealing with. So whenever in doubt, always seek help from a radiologist in as to what to order and what to interpret if we have already ordered an image. So in RPC, we have the advantage of having this neuro-radio clinic, and that's how it helps us. So the various neuroimaging techniques that we have are the computed tomography, which can either be non-contrast or contrast enhanced, or a 3D structure as well. Then in MRI, we can have various image enhancing procedures. I'll be discussing about it later on. So they are gadolinium contrast enhancement, flare, diffusion weighted or cis sequences. Then in angiography, we can either have magnetic resonance angiography or CT based, or it can be an conventional catheter angiography. And ultrasound, however, I'll be discussing mainly about CT, MRI and angiography in this presentation. So coming on to the types of scans, so whether it is CT scan or an MRI scan, all these scans are going to have three types of scans. So one is the axial scan. So axial scan is a cut which is taken just parallel to the ground. So if this is the brain, so this is the transverse plane, and this is what the view of an axial scan is going to be. Then coming on to the coronal section, so it is a cut which is taken along the frontal plane. So this is the view that you're going to get in the coronal scan. And similarly, we have the sagittal scan, in which this is the sagittal plane. Just parallel to the midline, you take sections, and this is the view that we get in the sagittal plane. Now coming on to CT scan, the principle of CT scan is attenuation of the X-rays by the tissues of various densities. So more denser the tissue, more attenuation of the X-rays would be there, and we will have a hyperdense lesion coming in, and vice versa for the other way around. So in cases of human bodies, bone appears as a white structure and air appears as black, and all these structures stay in between. So what are the various indications for CT? So although MRI can also be used to image those things which we can image on CT, however, the most important indication is an acute hemorrhage which can follow either a trauma or a vascular event. Apart from that, any trauma, it could be orbital or pertaining to head, any bony or sinus related pathology, we would prefer going for a CT scan. Any in optic disc drusen's, if they are at calcified stage, they can be picked up on CT scan. I'll show you some photos later on. And wherever there is contraindication for MRI, so if there is a pacemaker, if there is metallic implant in claustrophobic patients, we would prefer to go for a CT scan, because MRI is also a prolonged duration taking investigation. So these are few images where CT has helped us to arrive at the diagnosis. So here you can see there's an intraocular foreign body which is going into the orbit into the brain, and that could probably also lead to the injury to the optic nerve as well. So this is the CT orbit of a floor fracture, where you can see that the floor of the orbit is fractured and the inferior rectus muscle is entrapped. Then this is a CT scan of a patient of craniosynostosis, and you can see that there is a narrowing of the optic canal which could lead to compression of the optic nerve and subsequent loss of vision in the patients. This is the coronal section of CT scan of a patient who had a congenital superior oblique palsy. Now remember, in muscle imaging, we would prefer going for an MRI, but if we have time constraints or cost constraints, even a nicely done CT can give us the information that we require. So here, if you see on the left side, between this is the medial rectus muscle and this is the superior rectus muscle. So this muscle is the superior oblique. However, you cannot identify superior oblique on the right side in this case. So this was a case of congenital superior oblique palsy that we were dealing with. Then in case of calcified optic disc drusen, as I told you, they appear as hyperdense structures overlying the optic nerves, and three-dimensional reconstruction of the images can also be done, which can give you a better view of all the pathologies present at the in that particular patient. Now, certain intracranial pathologies can also be picked up on CT scan. So, for example, an occipital infarct will look like a hypodense lesion. Similarly, a supracellular mass will look like a hypodense lesion over the cellular area. and a cavernous sinus thrombosis, for example. So if you see this cavernous sinus, on this side there is a homogeneity which is present. However, this side there is some black areas which you can see. They are probably the areas of flow void secondary to maybe some kind of thrombosis. So coming on to MRI, the principle of MRI are, it uses signals which are derived from interaction of hydrogen protons within a magnetic field. The absolute advantage of CT scan over MRI is that it does not have any radiation risk. Apart from that, it also offers a superior contrast between the pathological lesions and normal lesions. Now again, types of MRI imaging can be broadly classified into T1 weighted and T2 weighted. So in T1 weighted, remember that fluid is going to appear black. On T2 weighted, the fluid is going to appear white. I'm just talking about T1 and T2, not going on to the other enhancement images as of now. So this is how you see. Then another thing which is important in MRI imaging is use of contrast and fat suppression. Now why fat suppression is important? Now you can see both these images are T1 weighted images. However, if you look at this T1 weighted image, you can identify the optic nerve here, but you cannot identify the optic nerve here because the surrounding fat is also kind of looking bright. So to identify the optic nerve, you actually need to suppress the fat so that it stands out. Similarly, the use of contrast. So the principle behind use of contrast is that whenever there is any inflammation or infection, there is breakdown of the blood-brain barrier. So the contrast is going to leak from there, and that is going to show up. So again, if you have done this contrast enhanced imaging without fat suppression, this entire area will appear bright and you cannot delineate the abnormality. So that's the importance of fat suppression in a contrast enhanced imaging. So this is the T2 weighted image where you can see this is the vitreous and here this is the CSF alongside of the optic nerve. Now coming on to the other image enhancements in MRI. So first is flare. So what do we do in flare is that we attenuate the signal in the fluid. The fluid is made dark wherever whatever pathologies are there, they still stand out. So this is the image. This is T2 weighted. And if you can, this is the flare sequence. So the difference you can see is that here the water is appearing white, that is CSF is white, but here the CSF is dark. So these are the periventricular plaques. So if this was white, you would not be able to identify these small plaques in the vicinity of that white area. So to make these more prominent, you have to make this fluid darker. So that's the advantage of flare. The next is diffusion weighted and ADC image. So this is this image, it measures the aberrancies in the Brownian motion of the movement. So this is particularly useful in patients who have acute infarct, because whenever acute infarct happens, it will cause the cell swelling and that will reduce the intercellular space, leading to restriction of the diffusion into that space. So that is picked up by the diffusion weighted images where it appears as a hyperintense lesion. And of course, there will be the diffusion coefficient will reduce in these cases. So this, in the ADC image, the corresponding area will appear to be darker. Then coming on to the cis sequence. So cis sequence are basically heavily weighted T2 images. So this is a flare sequence and this is the cis sequence. The difference is that in this flare sequence, you see the cistern area does not have much of the details inside it. But however, if you look at the cis sequence, you can see this finer structures, which is the probably 7 cranial nerve going into the internal caustic meatus. The blood vessels can also become more prominent in a cis sequence. Coming on to angiography, so it can be either non-invasive or invasive procedures. Nowadays, MR or CT based angiography is more commonly used as opposed to a conventional catheter angiography. So again, imaging, if you're imaging the arterial circulation, it is angiography. If you're imaging the venous circulation, it is venography. So arterial circulation imaging can be done and you can identify any stenosis, dissections or AV malformations. And venography can help you to identify any venous sinus thrombosis or venous stenosis. And of course, invasive procedure like conventional catheter angiography can also be done. So now I'll be talking about few interesting cases. So first I'll talk about few typical cases which we get to see routinely, and then later on talk about some atypical ones. So this was a case of a 19-year-old female patient who presented to us with chief complaints of diminution of vision, sudden in onset in one eye. After a clinical examination, we could reach at a differential of a left retrobulbar optic neuritis. This fundus was absolutely normal. And we ordered imaging of orbit and brain, contrast enhanced and fat suppressed, and T2 flare of the brain. So this was what we could see. On the left side, this is the T1 weighted contrast enhanced fat suppressed image. You can see that there is enhancement of the entire optic nerve. So normally a optic nerve will not enhance in concordance with the surrounding muscles. However, in this case, you can see that the optic nerve brightness is almost equal to that of the muscle. So that's the enhancing optic nerve. Then in the coronal section also you can see the same thing coming up. This is more bright as compared to this side. Then these are the flare images of the brain. So you can see the periventricular plaques and also the subcortical and the juxtacorticular plaques. And in the sagittal section, this is a classical description of Dawson fingers, which is seen in a patient with multiple sclerosis. So this imaging was helpful to us in diagnosis as well as prognosis. So we were able to diagnose the case of optic neuritis in a multiple sclerosis patient, and through the ONTT trial we have this, that if there are no MRI lesion, the patient has risk of development of MS about around 25%. However, if there are so many MRI lesions present, the risk increases to as high as 75%. Then this was the second case of a 24-year-old female who presented to us with acute onset severe bilateral diminution of vision. On further examination, pupil reaction was sluggish and fundus was absolutely normal. So again, based on our clinical history and examination, we made a differential diagnosis of an atypical optic neuritis and we ordered neuroimaging. So this was what we got. So this is again a T2 weighted image of the MRI. You can see the hyperintensities in both the optic nerves, and this hyperintensity is running up to chiasma. The same thing was reciprocated on the contrast enhanced T1 weighted image as well. You can see the contrast enhancement in the entire segment of the optic nerve, which was going up till the chiasma. So we had in mind that probably we are dealing with neuromyelitis optica spectrum disorder, because that's where we see the contrast enhancement going up till the chiasma. So we ordered a spine MRI as well, and in spine MRI in the cervicothoracic region we could note some hyperintensities again. So this was a case of atypical optic neuritis. So how neuroimaging helped us here was that normally we diagnose neuromyelitis optica disorder based on the blood investigations, which take a longer time as compared to the neuroimaging. So if it has been seen in studies that if we intervene early in patients with NMOSD with plasmapheresis as opposed to steroids, the visual outcomes are better. So that's how this can be advantageous to us. So this was a case of an atypical optic neuritis. Now these were the cases where we had a differential in our mind and the neuroimaging confirmed that differential for us. However, there were certain cases where clinically we thought probably we are dealing with optic neuritis, but when we ordered for neuroimaging, we found it was something else rather. So it was either something pertaining to brain or to the orbit. Now, this was a patient who was a 26-year-old male patient. He complained of sudden diminution of vision in one eye since 20 days. He went to a private practitioner where he was diagnosed to have low vision in one eye, that was hand movement close to face. There was an RAPD. Again, a clinical diagnosis of right eye optic neuritis was made, and the patient was given IVMP. However, there was no improvement in vision post IVMP, and when the patient presented to us, vision was still hand movement close to face. There was right eye RAPD and there was disc pallor in the fundus. When we neuroimaged the patient, we found something absolutely out of the picture, which was a pituitary macroadenoma with a hemorrhage inside it, which has probably led to increase in the size of the pituitary macroadenoma and causing the vision loss in the patient. So second patient was a 26-year-old female patient who had diminution of vision in one eye since 3 days. The vision was again finger count. There was an RAPD. Fundus was absolutely normal. Thought on the lines of an acute optic neuritis, but again we went back to see the imaging, so we found that the inflammation was not just limited to the optic nerve, rather it was present even in the surrounding muscles. So you can see that the inflammation is in the MR as well along with the optic nerve, and when we look at the coronal sections, this is the inflammation. So there is bulkiness in the MR, even in the IR, and some inflammation going around. So this is how we came to the conclusion that probably we are dealing with a non-specific orbital inflammatory disease which has caused a secondary inflammation to the optic nerve. Then this was another interesting case in which a 38-year-old male patient, he presented to us with sudden diminution of vision in both the eyes, which was severe. The pupil reactions were sluggish, fundus was absolutely normal. Again, we thought on the lines of that probably we are dealing with atypical optic neuritis. But when we did a neuroimaging, we found that there were hyperintensities in the putamen region. So there was a putamen necrosis. And this is something which is classical of methanol toxicity. And when we went back and asked for the history of methanol intake, we actually found it. And this finding of ours was confirmed after 2 months when we did the fundus photography and we found excavated disc with pallor, which is again a classical feature of methanol toxicity. Then this was a case of a 65-year-old male patient who had sudden diminution of vision in both the eyes. There was no other positive history, no systemic history, and the vision was very, very poor. It was PL positive, rest everything was within normal limits. So we did a neuroimaging. What we found was acute ischemic infarct on the right side of the occipital cortex and an old infarct with hemorrhage on the left side. So this was a case of a cortical visual impairment. Then this is another interesting case of a 57-year-old female patient who presented to us with chief complaints of diminution of vision in right eye since 2 months, and there was an associated headache as well. Vision was as low as finger counts, there was an RAPD, and the patient was a known hypertensive. So in these conditions, we would make a clinical diagnosis of a non-arthritic ischemic optic neuropathy and treat the patient accordingly. However, the patient was giving a very significant history of associated headache. So went on for a neuroimaging. The fundus showed right eye disc pallor as compared to the left eye, and this is what a neuroimaging came up with. There was an internal carotid artery aneurysm which was sitting near the optic canal and causing the compression of the optic nerve. So here, this is where our MR angiography was helpful. You can see this aneurysm area. So we were not dealing with an NAIN, rather we were dealing with a compressive optic neuropathy because of the IC aneurysm, and the patient was referred to neurosurgery for further management. Then this was a patient who had papilledema, a 33-year-old female, and had history of severe headache. Again, there was a severe grade 4 papilledema. And when the neuroimaging was done, we could see this distended optic nerve sheath on the T2 weighted images. You can see the CSF being very prominent over here. And in this sagittal section, you can see there is a flattening of the posterior sclera, which is again a classical thing which you see in patients with papilledema secondary to idiopathic intracranial hypertension. The other signs which we look for is the empty sella, which is found in 70% of patients with IIH. And on an MR venography, we found there was a transverse sinus stenosis that was present. So this was a case of IIH, and it was managed accordingly. Then this is another patient who presented to us with hyperdeviation of the right eye since early childhood. And on examination, we found that there was limitation of depression in the right eye. So again, we wanted to order an MR here, but we couldn't. So we went ahead with CT, and CT was able to tell us much about the disease. So this is the sagittal section of the CT. This is of the left eye. You can see this is the SR-LPS complex, which is nicely visible over here. This is the fat plane which separates the two. So in the right side, you can see that there is an increase in the bulk in the SR-LPS complex, and the fat plane has been lost. So there is some kind of maybe fibrosis or something that has happened on the right side. However, if you look at the inferior rectus, so on the left side, which is the normal side, you can see the orbital fibers of the inferior rectus and even the global fibers of the inferior rectus, which are going and inserting onto the globe. On this side, however, you can just see the orbital fibers and not the global fibers. So here we were dealing with the case of IR hypoplasia. Then neuroimaging can also help us to ascertain the causes of vision loss in patients with tubercular meningitis. So the various causes includes accumulation of basal exudates in the chiasma and near the optic nerve also, which can cause a direct toxic damage to the optic nerve, or it can cause an obstructive hydrocephalus because of the meningitis per se, or because of granulomas which can compress onto the ventricles, and then direct tubercular infection of the optic nerve or a drug-induced toxic optic neuropathy. So here the question is, then above 3, neuroimaging is going to present to us with some kind of findings, whereas in drug-induced toxicity, the neuroimaging will be normal. So neuroimaging, what you can find is basal exudate sitting at the chiasma, which can cause a direct toxic damage, or you can see multiple granulomas present near the chiasma again and the optic nerve, which can cause either a compressive or a toxic damage to the optic nerves. So this is another interesting case of a patient who was a 48-year-old male. He came to us with chief complaints of double vision in right gaze. So clinically looked like a 6th nerve palsy, but when we actually examined the patient had horizontal uncrossed diplopia in the right gaze, but there was no concomitant esotropia. Along with that, there was a congestion in the right eye, and the right eye seemed to be slightly proptossed as well. So we went ahead with the imaging, and what we found was that there was increase in the bulkiness of all the muscles on the right side when compared to the left side, predominantly LR, MR and IR. And when we looked at the axial sections, we found that the muscular belly part is actually swollen and the tendons are actually spared. So this finding, coupled with the findings of the eye, taught us that probably we are dealing with a case of unilateral thyroid eye disease, although uncommon, but still the patient was investigated on these lines. Now, the indications of neuroimaging in patients with cranial nerve palsies are that all children who present with cranial nerve palsies needs to be imaged, and any patient who is less than 45 years of age needs to be imaged. If a patient is more than 45 years of age and you do not find any cause which can cause an ischemic mononeuropathy in those patients, you of course need to image that patient as well. So patients who have got multiple nerve palsy, so suppose a patient presents to you with a combined 3rd and 6th palsy, you can think that probably there is a lesion sitting in orbit or in the cavernous sinus. You need to image that patient, or if there is a bilateral involvement, which would point towards a nuclear involvement. So patients with any other orbital pathology, neurological signs of trauma history, as in the previous patient, he just not had an LR underaction, but there were other signs as well. That's why we went ahead for a neuroimaging that patient. So patients who are known to have any kind of cancer, of course, they need to be neuroimaged. Any progressive or a non-resolving nerve palsy. So although ischemic mononeuropathies, we say no need to image at the first go, but if you see that they are not resolving or they are progressing over the period of time, then of course you need to intervene with a radiology investigation. Then pupil involving third nerve palsies or the one with aberrant regeneration definitely needs to be imaged. So to summarize, I would just like to reiterate the fact that the bedrock of clinical localization is a focused history and a thorough examination. Don't turn your ears away from it, because if you do so, you will land up in a lot of diagnostic problems. So that warning which is written on most of the MRI reports that kindly correlate clinically, please take it seriously. Thank you.
Thank you, Dr. Monica. That was an excellent and very exhaustive coverage of imaging technologies available and their role that we need to know. So the key message of this is that you need to identify or localize where your lesion is and convey, and your likely diagnosis, and convey that to the radiologist. More often than not, if they just do a screening images or they are not knowing where exactly to look for, we may frequently miss these conditions that are there, and the report just saying that it is normal may mislead us and actually delay the identification and management of the concerned problem. So in many of these cases that you were seeing, the key element was a suspicion of where the lesion is and to give an idea about what and where we need to see. So appropriate investigation, appropriately directed. I would welcome Professor Radhika Tandon to the workshop. Dr. Tityal, our chief, is currently not here, he's abroad, so we have the next best thing, Dr. Radhika, who is gracefully, she has come and agreed to inaugurate this workshop. When I joined as a resident, Madam was in the Neuro-Ophthalmology Instruments service, so she actually has been my teacher in this specialty, and therefore it would be wonderful that we can hear her words of encouragement and her experience in this workshop. So welcome, ma'am. Thank you for coming. We just welcome you. Ma'am, we'll do the inauguration, we'll keep doing the discussion. We have all day for discussions. We're going to have a lot of cases also. So I hope the just past sessions were good. I'll request Dr. Swati to please welcome ma'am with a small feng shui. Thank you, ma'am. If we could have a few words from you.
Good morning, everyone. It's a nice Sunday, and nice to see so many people here in the audience, as well as people who join online. I'd like to thank Professor Rohit Saxena, who has now, from being a resident, has risen to be the chief of neuro-ophthalmology at RP Center, which is a very, very prestigious and a very responsible position. And along with him, he has a wonderful team of faculty and residents, and I really appreciate the way they have put together this workshop, and appreciate everybody for having been taken the time to come here. So I'd like to welcome all the delegates and all the participants. Just a few words about neuro-ophthalmology. It's a very special specialty from the ophthalmology point of view. Apart from neurological diseases which are known to have ophthalmic manifestations, there are many serious neurological conditions which may first present to the ophthalmologist, and the ophthalmologist has a great responsibility from that angle also. And it's very important that this knowledge is understood across the board, even among general ophthalmologists, because not everybody will be a neuro-ophthalmologist and the patient will just go to an ophthalmologist. So therefore, workshops like this are extremely important, that they sensitize everybody to the various conditions. And everybody has their own spectrum of interest and the level of knowledge. Of course, some people just find neuro-ophthalmology too complicated because you have to remember all the pathways and all the connections. But basic principles we cannot let go of. And no better place than RP Center with the entire Neurosciences Center, Neuro-Ophthalmology, as well as Neurology and Neurosurgery departments to support us. This is the best place to learn. And this is a specialty which has changed a lot over the years. Basics have remained, but with greater imaging and both in the neurological point of view as well as the ophthalmology point of view have helped us understand, detect things earlier. And even in terms of surgeries, there's a lot of scope for what can happen. So with that, I'll firstly congratulate everybody and welcome you all, and I hope you enjoy the workshop. I do have somewhere else to go, so I'll wait for a little bit just to sort of listen to the discussion and maybe interact with you for a short while, but please excuse me if I won't be able to stay throughout. Thank you.
Thank you very much, ma'am, for the very encouraging words. And even now, ma'am takes a very keen interest in neuro-ophthalmology, and I have to be very careful on the advice I give to patients. Ma'am refers back to me because ma'am actually goes and sees what I have written and she will discuss with me. So, I have to actually be very careful. And this is actually true for almost all the faculty here. It's always a good check and feedback that it prevents you from thinking that you know it all. So, thank you, ma'am, for being here. I think we'll take a quick tea break so that we can recharge a little bit of our grey cells. We've had a nice, interesting session, and then we'll come back with our approaches to the various diseases and how to manage them. So we'll be back in about slightly under 15 minutes. So we'll just start bang as we had planned at 11 o'clock. Thank you. चेक कर लेना बाकी के चल रहे हैं वेरी गुड वे मेलिना ने गाना एक थोड़ा सा ये रहते इसको बोलते हैं नेचुरल ट्रैंगुलर है क्या ये स्पीक लेकिन मैं इनकी ग्रेजुअली सेट डाल मैं धीरे
मेरे को पता है मैं also overshoot इसलिए हम try किए टाइम
नहीं क्या टाइम हो गया ठीक है 15 मिनट 15-20 मिनट में हम लोग बैंक लेवल चलेगा वेरी नाइस
मैं तो पहली बार एडिटिंग
when to do. And maybe we'll have a little bit of discussion when we are discussing cases. So maybe some, like I said, maybe some of the questions you have in your mind about what to do and how to do may get answered as we are discussing the various kinds of cases that are there. Else we'll take up discussion subsequent to our cases. If there's anything very pressing, then you can obviously ask after every presentation, but for long answers or more approach-wise or discussions, maybe we'll kind of discuss them after or during the cases. So we'll now move to the approach you need to have in neuro-ophthalmology and related conditions. We have Dr. Himani, who's going to talk about analyzing disc edema and what are you going to do when approached with a patient with disc edema. Dr. Himani, please.
Good morning to one and all. I welcome you back to the second session of our conference today. I'll be talking about approach to optic disc edema. So before labeling something as abnormal, we should first know what is normal. So a normal disc, as we have already discussed, is a vertically oval disc with proper well-defined margin with a cup-disc ratio of around 0.3 to 0.5:1 with a regular healthy orange-pink neural retinal rim, and vessels in peripapillary area tell a lot about what is happening to the disc. So defining optic disc edema. Optic disc edema refers to edema of the intraocular part of the optic nerve associated with swelling. So there are mechanical signs and vascular signs for the same. Mechanical signs, as we can see, include loss of cup, elevation of disc, blurring of the disc margins, nerve fiber layer edema, and retinal or choroidal folds. And the vascular signs consist of disc hyperemia, dilation and tortuosity of the peripapillary vessels, peripapillary hemorrhages, cotton wool spots, and exudates. So optic disc edema can be classified as bilateral and unilateral. Bilateral optic disc edema causes can be pseudopapilledema, papilledema, diabetic papillopathy, malignant hypertension, bilateral papillitis, compressive optic neuropathies, inflammation, toxic metabolic diseases, and asymmetrical optic neuritis. Unilateral disc edema can be divided into hyperemic and pallid, as in AION. Hyperemic unilateral optic disc edema can be pseudopapilledema, papillitis, neuroretinitis, NAION, venous congestion, ocular inflammation as in intermediate uveitis, ocular hypotony, and diabetic papillopathy again. So sometimes people use papilledema and disc edema synonymously, but we must remember that papilledema should be exclusively used for a true disc swelling which is caused by a raised intracranial pressure. It is usually bilateral, and there are history suggestive of raised ICP. Like patient will tell you about the history of nausea, vomiting, headache, transient visual obscuration, and diplopia due to 6th cranial nerve palsy. Visual field defects, most commonly blind spot enlargement, but in chronic papilledema, there might be arcuate field defects or even generalized field depressions. This is one condition which requires urgent attention. Causes of raised intracranial pressure can be intracranial space occupying lesion or inflammations like meningitis or encephalitis. It could be hydrocephalus, which can be further due to increased CSF production or CSF obstruction, or causes pertaining to vessels like subarachnoid hemorrhage, intracranial bleed, and eventually will be left with idiopathic intracranial hypertension if none of the above diagnoses are true. So the investigation of choice is MRI, and in some cases we can order MRV or even CT for the same, but our investigation of choice will be MRI. Serology and lumbar puncture will be done based on our suspicion. So papilledema can be graded as per the modified Friesen scale. So grade 1 we can see is a greyish C-shaped halo surrounding the disc. Grade 2, the halo becomes circumferential and there is slight nasal border elevation. In grade 3, there is elevation of all the borders and there is obscuration of at least one vessel leaving the disc. In grade 4, there is obscuration of a major vessel on the disc, and obviously there is complete elevation of the cup. In grade 5, there is obscuration of all the vessels on the disc and leaving the disc. Idiopathic intracranial hypertension is most commonly present in obese women of childbearing age. So 90% are women, 90% are obese, and most commonly present in third decade. It is associated with sleep apnea and exogenous substances like vitamin A, tetracycline, lithium, even corticosteroids. It is diagnosed as per the modified Dandy's criteria, wherein there should be symptoms and signs of raised ICP, but no localizing signs in the neurological examination except for sixth nerve palsy. The neuroimaging should be absolutely normal except for some signs that Dr. Monica discussed. Opening pressure of the lumbar puncture should be more than 250 millimeters of water. The patient should be alert, awake, and there should not be any other cause of raised ICP. So whenever we come across a patient with optic disc edema, the first thing that we need to ask ourselves that is this edema or is this pseudopapilledema? So pseudopapilledema is a swollen disc which is not due to axonal swelling. We already discussed that papilledema may have decreased vision, may affect pupillary responses, the optic cup is obscured, the vessel is obscured, the capillaries are distended. But in pseudopapilledema, almost always the vision is normal, pupillary reflexes are fine, the optic disc appears to be a small cupless disc, but the vessels are not at all obscured. The vessels can be visualized as they leave the disc. There might be some abnormal branches, and if in cases of difficulty, we can order an FA. In papilledema, there is disc leak present, but not in pseudopapilledema. So some common causes of pseudopapilledema are myelinated nerve fiber layer, tilted optic disc, hypermetropic disc, and optic disc hypoplasias. So to my right is an image which shows multiple hyperreflective body suggestive of exposed optic disc drusen. To my left is an image. We can see a lumpy, bumpy disc. There is blurring of the superior and inferior margins. We diagnosed it as query buried optic disc drusen. We ordered in a FAF, but it was normal. Then on EDI OCT, as Dr. Asmita told you, we could appreciate a central hypoechoic area with the surrounding hyperechoic zone. So we diagnosed it as buried optic disc drusen. When we talk about hypertensive retinopathy in stage 4 of modified Shees or Keith-Wagner, and in severe malignant hypertension in Wong-Mitchell classification, we talk about optic disc edema. So optic disc edema in that case is due to leakage and ischemia of arterioles which are supplying the optic disc. So risk factors for malignant hypertension, they include degree and duration of elevated blood pressure, obesity, history of tobacco and alcohol use, and stress. Diabetic papillopathy can present, the patient can be absolutely asymptomatic or can have non-specific symptoms like blurring of vision. The etiology is microangiopathy, although rapid blood sugar control have also been associated with diabetic papillopathy. Some people also consider it to be a spectrum of NAION rather than a different entity. On fundus, the disc appears hyperemic with marked dilation of the microvasculature. On FA, the disc and peripapillary leakage, there is a radial distribution of the dye. This is to be differentiated from NVD, where the pattern of the vessels is very random and there is leakage there is intravitreal leakage. So we talked about bilateral disc edema. So after a thorough clinical workup, we measure blood pressure and blood sugar. We treat hypertension and diabetes, if any. In cases where normal blood pressure and blood sugar is there, the first thing that we want to do is rule out pseudopapilledema. After that, we would like to go for neuroimaging. And if in neuroimaging we find any mass lesion or any cause of raised ICP, we refer it to the concerned specialty. But in case of normal imaging, we would like to go for lumbar puncture and CSF study. So if CSF findings are suggestive of meningitis, we like to treat the underlying conditions. If the CSF opening pressures are raised, we are left with the options of IIH. And if the CSF opening pressures are also normal, then we must review and reconsider our diagnosis and rule out other causes of pseudopapilledema. Coming to our unilateral causes of optic disc edema, optic neuritis. So a young female patient comes up with subacute vision loss, unilateral with painful ocular movement, dyschromatopsia out of proportion to vision loss, optic neuritis. So it can present as retrobulbar papillitis or neuroretinitis. In retrobulbar, the optic nerve head will appear normal to us. In papillitis, there will be disc hyperemia and swelling, as we can see. It is most commonly associated with post-viral and infectious neuritis. Neuroretinitis in neuroretinitis, there will be optic nerve head edema associated with macular star formation. What we want to do is neuroimaging because, as already discussed, we want to know the risk of multiple sclerosis and also if there is any associated acute myelitis. Ischemic optic neuropathies can be divided into anterior and posterior based on the segment of optic nerve they are involving. Anterior ischemic optic neuropathies include 90% of ischemic optic neuropathies. They are divided into arteritic and non-arteritic on the basis of their etiology. So, arteritic anterior ischemic optic neuropathy is less common. The mean age of affection is 70 years with female predilection. There are symptoms of GCA like headache, scalp tenderness, jaw claudication and transient visual obscuration. It presents with severe vision loss. As compared to non-arteritic anterior ischemic optic neuropathy, which is more commonly encountered in our practice, the mean age is around 60 years, no gender predilection, and presents with a mild to moderate vision loss. On fundus, AION presents as a pallid optic nerve head edema plus minus cotton wool spots and choroidal retinal ischemia. NAION can have a hyperemic disc edema with small cups. ESR and CRP are elevated in AION and normal in NAION. Arteritic anterior ischemic optic neuropathy, it rarely involves, and the fellow eye is involved in around 95% of cases within days to weeks. So the goal of our treatment is to prevent the disease in the other eye. So for that we give systemic corticosteroids. NAION generally 31% improve, and around 20% of patients the fellow eye is involved in 5 years. NAION, as I told you, is more common, less severe vision loss, hyperemic disc, altitudinal field defects, and etiology is compromised optic nerve head microcirculation. So to summarize, I cannot emphasize enough on the advantages of a proper history taking and general physical examination. We have to take proper visual acuity, color vision, contrast sensitivity, get the intraocular pressures tested, thoroughly check the pupillary response, look for RAPD, evaluate the anterior segment to rule out any signs of intraocular inflammation. Then we'll go along and dilate the fundus, do slit lamp biomicroscopy, get a baseline fundus CP done, baseline visual fields and RNFL OCT done, which can also help to us to check for the progression of the disease. And in cases of unexplained disc edema, we would like to consider neuroimaging, and if that also comes within normal limit, then we would like to go for lumbar puncture to look for opening CSF pressure and CSF evaluation. So that is how you would approach a case of optic disc edema. Thank you.
Thank you, Dr. Imani, for how to approach a patient with disc edema. We'll have Dr. Priyanka talking about approach to disc pallor. So the disc responds to any kind of insult in just 2 ways. In the initial period, it will just swell up, and later on, it will just, as they say, just lie down and die. So that's the only 2 kind of responses you see. And effectively, edema and pallor are not really always telling us what we are trying to pick out of it. So often it gives us very little information, but because want of being able to do extensive investigations that are available as a possible route to do deeper investigations, it's more important to see more closely and try to get the hints so that it gives you an idea what to go on. So Dr. Priyanka will be telling about those subtle things you need to see when confronted with disc pallor, as to how you would direct your approach towards investigations and differentials. Dr. Priyanka.
So, good morning everyone. The ocular examination, the investigations and the other modality which will help us to clinically approach a patient with any optic nerve pathology has already been covered in the previous talk. So I'll be talking mostly about the various etiology and overall approach to how to approach a disc pallor. So disc pallor is a sequelae to various optic nerve disorders, and it signifies a partial or a total optic atrophy. It may present with symptoms and signs which can range from a subtle visual dysfunction to a total blindness. So a pale disc can be because of a decreased vascularity, capillary dropout areas, gliosis, or the visible scleral lamellae. So, the demographic profile of the patient, a thorough clinical history, detailed ocular and systemic examination, relevant investigations are important when we approach towards a clinical approach towards a patient who present to us with this pallor. Age probably is the most important demographic parameter which will help us to enlist the various etiologies which for the disc pallor. So in children, hypoxic ischemic encephalopathies, hydrocephalus, nutritional toxic causes, the neoplastic causes, trauma and hereditary optic neuropathy are the causes which we have to look into them. In the adolescent age group, LHON, atypical optic neuritis, toxic optic neuropathies, traumatic causes, pituitary adenoma are the important causes which we should look into. For the young adult, it is inflammatory infective optic neuropathies, then traumatic, IIH, toxic, hereditary retinal dystrophies and other hereditary optic neuropathies. In older adult, it's usually, it's mostly ischemic and compressive and infective etiologies which should be ruled out. So, clinical presentation of visual dysfunction can be acute, subacute or insidious in onset. If we talk about the acute onset, that is from in hours to days, can be optic neuritis, ischemic optic neuropathies and traumatic optic neuropathies, while subacute onset is usually seen in non-demyelinating inflammatory optic neuropathy, compressive optic neuropathies, and insidious onset, which is slow and progressive, is seen in toxic, nutritional and hereditary optic neuropathies. So if we see the course and we see that this, the visual dysfunction is self-resolving without any intervention, or there are recurrent episodes, we will think of a demyelinating pathology. And if there is a residual poor vision or there is a progression, we should look into the other causes such as compressive or toxic. Based on laterity, it can be either unilateral or bilateral. So unilateral causes for an optic atrophy or a disc pallor can be a typical optic neuritis, non-arthritic ischemic optic neuropathy, traumatic optic neuropathy, and compressive lesions of the optic nerve, while the bilateral or asymmetrical presentation can be seen in toxic optic neuropathy, nutritional optic neuropathies, hereditary, atypical, and arthritic ischemic optic neuropathies. So, ophthalmoscopy examination of the disc and the fundus gives us three categories broadly based on the appearance of the disc. So, primary optic atrophy shows a chalky white disc with chalky white color disc with a well-defined margin and a cup with visible lamina cribrosa. The retinal vessels and the surrounding retina are within normal limit. So this kind of optic atrophy is usually seen in cases of retrobulbar optic neuritis, compression by the intracranial tumors, aneurysm, trauma, and hereditary optic neuropathies. So the secondary causes of optic atrophy, the disc appears dirty gray in color with ill-defined margins. The physiological cup is obliterated. There is a peripapillary sheathing of the retinal arteries, and it is mostly seen after post-papilledema or post-papillitis cases. So if we talk about the consecutive optic atrophy, the disc appear waxy, pale in color. The disc margins are normal. There is a normal physiological cup, but there is a marked arterial attenuation associated with retinal pathologies, and the various retinal diseases like retinitis pigmentosa, choroiditis, extensive pan-retinal photocoagulation, CRAO can show such kind of optic atrophy. So clinical history is important to elicit the signs and symptoms of an optic nerve dysfunction or a space occupying lesion. Systemically, a vasculitis or systemic illnesses such as hypertension, diabetes. Rule out any trauma, any previous history of use of medications like toxic drugs, ethambutol, etc. Occupational and social history is important to look for alcohol and smoking history, and the family history for ruling out a hereditary causes. So ocular examination has already been done in detail by Dr. Aishwarya. So coming to the disc with the point of view of ophthalmic, from the point of view of disc pallor, so we have to look the size of the optic disc. A small optic disc is a risk is disc at risk and is a risk factor for ischemic optic neuropathies, while the color will help us to differentiate between primary, secondary and consecutive optic atrophies. A deep excavated cup is more pathological than a shallow cup. Also, decrease in the capillary count, that is the Kastenbaum number, is seen in optic atrophy, and presence of a peripapillary atrophy, thinning of the retinal nerve fiber layers, and the neuroretinal asymmetric neuroretinal rim with focal notching or losses will point more towards the glaucomatous optic atrophy. So, in a ischemic optic neuropathy, we can see that there is a sectoral pallor of the optic disc, and corresponding visual field can show a altitudinal field effect, while the fellow eye can show a disc at risk kind of a picture. And hence we need to evaluate the patient for hypertension and cardiovascular diseases. A typical optic neuritis will present with a unilateral normal looking disc or a mild temporal pallor, while an atypical optic neuritis will present more like a papillitis kind of a picture, and it can be bilateral. And here the contrast enhanced MRI to look for optic nerve enhancement, any other demyelinating pathology is warranted. Infectious etiologies such as viral and Katkes disease can present with unilateral or bilateral disc edema with a macular star formation. Toxic or nutritional causes such as ethambutol toxicity, alcohol and smoking, and vitamin B12 deficiencies can present with a temporal disc pallor in the early stages, which can later become diffuse. It is usually bilateral, but in early stages it can be asymmetrical. So Leber's hereditary optic neuropathy present with a sequential bilateral vision loss, temporal disc pallor with RNFL defects in the papillomacular bundle. In the acute stages, they may demonstrate a pseudoedema with disc hemorrhage and peripapillary telangiectasias. The lesions involving optic chiasma and the optic tract will usually involve the bilateral optic nerve, and usually the disc pallor is more than the cupping in this case, and the bow tie atrophy of the contralateral disc can be seen in few cases. Compressive neuropathy, the most important causes are the compressive lesions of the optic nerve such as gliomas, the meningiomas, schwannomas, and also sometimes thyroid orbitopathies, usually present with a unilateral disc edema or a disc pallor kind of a picture with a secondary atrophy of the optic disc, sometimes can be associated with optociliary shunt and disc collaterals. Traumatic anterior lesions or anterior traumatic optic neuropathy will present with either optic nerve avulsion or a disc pallor associated with fundus findings such as of commotio retina or choroidal ruptures, while posterior lesions will present with a late onset disc pallor. So, systemic workup to rule out the systemic workup, general physical examination is to rule out any toxic causes or any nutritional deficiencies, while lymphadenopathies to look for any tuberculosis or any other causes of lymph node enlargement. Cardiovascular examination will include pulse, BP, ECG, carotid Doppler, hemogram, and peripheral smears with ESR's lipid function test. In cases we are suspecting ischemic optic neuropathy, central nervous system examination along with neuroimaging, CSF analysis in suspecting cases of demyelinating inflammatory, vascular degenerative and space occupying lesions. These are the list of specific tests which will help us to confirm and conclude the definitive diagnosis. So to conclude, I would say that optic nerve pallor is the end result of any insult which is occurring to the optic nerve. So we have to go back and do a complete detailed examination of the be it ocular, systemic or any other relevant investigation to come to a definite diagnosis. Thank you.
Thank you, Dr. Priyanka. And as it has been said that both disc edema and disc pallor are not a disease in itself, they are just a manifestation of disease. So how we proceed, how each case presents differently, and how each case has to be investigated, this kind of approach will be given by case-based approach for disc edema by Dr. Rohit. So Dr. Rohit, please.
Thank you, Dr. Swati. Thank you to all senior residents who've given this very excellent background overview of the various conditions that we see how to work up. So we can now discuss case-based. If you have any questions in the middle on any question on any of the cases we are going to talk about, we are open. Otherwise, as I said, we can probably discuss them subsequent to the case presentations. I'll be talking about a few cases of disc edema. Dr. Swati would then be running through our overview of different cases of disc pallor, so that we cover up all the various conditions that we see. So you've seen this table, which Dr. Himani so nicely put up. So whenever you see disc edema, think bilateral, unilateral. Bilateral, you have a whole lot of diseases that you probably require systemic neurological workup. You have unilateral, the key thing to know is what's going on in the other eye, whether it's normal or there is something else. So if it's normal, then you're kind of concentrating on this side, but you need to worry about what's going on in the other eye. So that's the key thing. This disc edema, whether it's hyperemic or pale, and we've gone through the various conditions. And of course, if the other eye is optic atrophy, probably the event that's happening in this eye today has already happened in the other eye previously. And looking at the course, trying to understand what was going on, what happened to that eye, it would tell us what we are looking at, and of course increases the urgency for us to do something, because if the other eye is very poor vision, it's likely that this eye will go into that bad a case or condition. So let's look at this 30-year-old girl who came to us with decreased vision for 2 months. It was bilateral, simultaneous, insidious onset, progressively worsening. She had history of transient obscurations of vision, a very, very important history which many patients give, or you may require to actually elicit in many conditions. She had associated headache, again something not very unusual. All of us have headache, and I'm sure all of you would be having once you go from here, but that would not mean that it's pathological. So our clinical examination showed pretty significant poor vision, both eyes. There was no limitation of ocular motility. She was overweight. There was no other systemic or neurological problems on a comprehensive workup. This was her fundus appearance. You can, and of course, this fluorescein angiography is not essential, but just for academic purposes, we did it. Of course, also to identify, is there any real function in the optic nerve? So you can see that this is going into actually atrophy. Here there is a little bit of edema. You can see a couple of hemorrhages here, showing that there is still some fluid. So possibly some nerve fibers are still intact, which have swollen up. So once the entire nerve fibers have atrophied and there is no nerve fiber, you will actually stop seeing any edema, and then it's just going to be flat. So that is like atrophic stage of papilledema, or atrophic stage of any insult to the disc. And here you can see there is some bit of edema, so probably there are some fibers left. You can see a little bit of staining of the disc. Here you can see virtually no staining. So this was the visual evoked response. Again, not always necessary, but in this case we wanted to know that does any intervention have any role in outcome. So that was the key reason why we were investigating her, because unfortunately she did not even have navigable vision. So can we do something for her? The rest of the MRI brain with contrast was normal. This is just showing you coronal cuts of the at the orbit level, and you can see these are the donut sign as they call it. You can see a lot of fluid on the optic nerve, around the optic nerve in the sheath, and these are rather small atrophic optic nerve. So showing that there is a lot of fluid in the perioptic space, and based on the above, we came to a diagnosis of idiopathic intracranial hypertension, extensively discussed all kinds of findings. So now IIH is essentially a diagnosis of exclusion. That is a must to remember. Must do an MRI to rule out a space occupying lesion or any other cause. If MRI is normal, must do an MRV to assess the possibility of venous sinus thrombosis, because that is the most important or most highly likely cause frequently, and of course will require a little different kind of intervention or an additional intervention. And MRV will help us to rule out a venous sinus thrombosis. Of course, an MRI can help us to pick up large tumors that can also present with disc edema. So the management of such a condition would be, of course, you look at the visual functions. More often than not, that is the key to your decision making. If it's not so significantly affected, you can start medical therapy and monitor and follow up the patient. Does the patient improve or is there worsening? If there is significant worsening or you are starting off with poor vision at the very outset, you may think in terms of surgical intervention. Medically, stop any drugs that may possibly increase the intracranial pressure, decrease the weight. It has been shown, in fact, one thesis done under Dr. Swati, we found that decrease in vision significantly helped in controlling IIH and helped to resolve much of the problems the patient had. So decrease in vision, in weight, of course, very difficult, I can tell you personally, but is a very sheet anchor role for intervention. Control blood pressure, look for anemia. These are all risk factors that per se may not be the only cause or only reason why such a thing has occurred, but put together in a patient susceptible, you may have IIH. So counter anemia, ask for obstructive sleep apnea. So CPAP, for if there is sleep apnea, all these things are very, very useful in helping in overcoming raised intracranial pressure. The sheet anchor intervention is oral acetazolamide and is very, very effective. Please remember to give it in doses that are effective. So very low doses or homeopathic levels of doses are not going to be very effective. So adequate doses of acetazolamide, diuretics and topiramate. Again, topiramate is a very preferred drug from a neurologist point of view, although we are a little afraid of the drug considering the very, very rare evidence of angle closure that has been associated with it. But it also helps to overcome the headache and also has been shown to give a little bit of help towards weight reduction. So this is important, although as an effective drug per se for reducing the intracranial pressure, acetazolamide remains the sheet anchor. Surgical options, from our perspective, the optic nerve sheath fenestration is the intervention that we are looking at. Of course, CSF shunt procedures, which reduce the overall pressure, would be in the realm of a neurosurgeon. So how would you think of where to go? More often than not, it's the neurologist who's giving needs to do these decision making. But if a patient has progressive vision loss, which is the most important problem in the long term that these patients face, think in terms of an optic nerve sheath fenestration. If headaches, very sudden or very severe raised intracranial pressure, think in terms of shunt procedures. So sometimes the patient has come with very, very high, more than 900, which is not measurable anything beyond that. Then ONSF as an intervention is not very effective because it does not reduce the pressure significantly, essentially reduces the perioptic pressure, which is responsible for the damage to the optic nerve function. So that's the important thing. If progressive vision loss is the primary problem and that requires intervention, ONSF is your aim. If it is a lot of headaches, motility defect in the form of 6th nerve palsy, a lot of general malaise, severe throbbing headaches, these are think in terms of a neurosurgical intervention. Of course, a comprehensive evaluation is very, very important. Please remember to advise the patients about the fact that it can recur, as well as recovery of vision may not always be that comfortable. So I'll just show you a video of an optic nerve sheath fenestration. It's done just like the way you do any strabismus surgery, using a limbal incision. You hook the medial rectus. We prefer to do it from the medial rectus side. Other techniques are described, but this is the best and the fastest. You disinsert the medial rectus. This is a traction suture, was called the baseball suture, but because we are in India, we can call it the kukubara suture. Or the Multan suture, or wherever the balls come from. This is helpful in pulling the globe and abducting it. You have this long blade retractor and you can see the optic nerve. We just separated the short posterior ciliary arteries and vessels so that they don't get injured in your incision. Intermittently, remember to relax, and we use a straightened keratome and we make an opening into the sheath that you can see. So that bulge is visible, and you need to go in and make sure that your entry is complete, and that will be seen by a fluid release that will happen as the entry is made complete. You need to go very parallel to the sheaths that you don't damage the nerve. You just an opening may not be enough because it will get closed, so you need to make a window and remove a small piece so that it remains open. And although some people have described putting mitomycin C, but I think it's not a good idea to put mitomycin C right next to the optic nerve. Subsequently, you just put back the medial rectus where at the original insertion, so that there is no long-term motility defect, and of course close the conjunctival incision like you normally would. So this was a case which we started off with. You can see that the edema has definitely come down, the hemorrhage is kind of resolving. She actually went on to get a 6/18 vision both eyes, although the nerves remained fairly atrophic. And as was pointed out, the appearance of the disc may not necessarily correlate with the visual function. So while there was very, very severe atrophy, she still managed to have a fair amount of central vision, although her peripheral vision was fairly affected. This was the kind of field she had. So although she had central vision, her field was fairly affected. So confirm the diagnosis of IIH, you need to be comprehensively evaluate the patient, investigate whatever necessary. Early intervention will give good outcomes. Do not wait for severe vision loss. However, like in this case, delayed intervention may give suboptimal results, but often may at least give enough for the patient to work. So now this was this case of a trauma, or really was it trauma? This 19-year-old male presented with complaints of diplopia for the last 12 days. He gave a past history of trauma to the left side of the head about 4 months ago. Now, could we say it's post-traumatic 6-nerve palsy? He was 6'6", anterior segment was normal. You can see the motility defects. He's having diplopia and levoversion. You can see there is a little less than normal movement as you compare to the other side. So, 6-nerve palsy post-traumatic, but delayed post-traumatic 6-nerve palsies would be rather not something which we would think in terms of. You look at the fundus and you can see this is the image of the fundus. There was raised intracranial pressure. But what was the cause of raised intracranial pressure? Young, male, not at all overweight, no drugs, nothing. So not a patient who's fitting into our conventional IIH diagnosis, but anyway we needed to image. So this is the image here you can see. You can see this large subdural hematoma, a midline shift, distended optic nerve sheath. So this patient had a subdural hematoma, gradually increasing intracranial pressure, causing the raised intracranial pressure, causing papilledema, causing 6-nerve palsy. So again, imaging appropriately directed is very, very important. The hematoma drainage surgery was done, there was resolution of diplopia, the patient was well. Another 40-year-old male came with near vision difficulty only and occasional headaches. This was the appearance of the disc. He had been extensively evaluated outside, told he has raised ICT, all kinds of investigations were done. But we've seen this kind of discs before in this presentation. And so you can see this lumpy, bumpy appearance of the disc, although the peripapillary area also again doesn't look clear, but on this nasal side where there doesn't appear to be any drusen's, you can see it's a fairly sharp margin. The other thing, notice that the vessels as they are moving, this is the other important thing. Firstly, please remember, no disc assessment on a monocular examination. I mean, a 2D examination of the disc does not serve any purpose. You need to do a stereoscopic examination using 90D, and preferably, if you can, dilate the patient. An undilated disc assessment often misses many of the subtle findings that you're looking for. And so, unless the finding is very gross and obvious, you probably will be able to see it even in an undilated pupil. But subtle findings, when in doubt, please dilate the pupil. So here you can see, these vessels, they are rather straight. Normally in a disc, if there is only disc edema, even if there are no hemorrhages or anything, you will see it bend. Like in this case, you can see, you can quite make out the three-dimensional movement of this. It loops up, then goes down and bends and goes straight. So if there is true edema everywhere, you're going to see these vessels go over it, slowly slope as they move away from the disc. So this is just a localized lesions that you are seeing. We did an ultrasound, you can see the high spiky return that you're seeing. So there's a fair amount of calcium here, so a disc drusen. This is a very subtle visible drusen. Another patient, a very subtle visible drusen here. So again, detailed magnified examination of the disc. 30-year-old female came with headache, and like I said, headache is a rather common complication, symptom that people come with. So, but it can have a rather serious connotation. So, complain of diminution of vision in both eyes for 1 week, dull headache, nothing else. Both eyes you can see significantly affected vision. This is the fundus finding. So, anything that we can think of in this patient? Sorry? Yeah, great. So, if you look at this, again, a patient was told he has papilledema, she has papilledema. Again, otherwise fits into everything that we've been thinking in terms of IIH. But you look at the disc, there's hardly any significant edema. There's a little bit of edema here, there's hardly any edema here. The other thing you notice that there is a lot of involvement that you can see, and you expect a lot of involvement in IIH. But a lot of this involvement, especially the exudates, the hemorrhages, they are away from the disc with a normal retina in between. So, if it is because of the disc problem, you're not going to have normal retina in between. Maybe the fluid gets absorbed, you'll see some exudates settled there, a streaky line of exudates showing that the edema is actually resolved, but you're not going to have normal retina. So, it's something else away from the disc. This patient had high blood pressures, and that was the cause. So, just going on with the findings, just showing you that this was the patient and these are the differentials. So, this is an IIH or papilledema, true papilledema. You can see that the vessels here, of course, are absolutely obscured. You can't see anything. There are a lot of exudation here. It's gone right up to the macula. It's a hemi kind of a star. A full star usually you do not see in papilledema. It's more likely to be in neuroretinitis. Usually because it rarely is so much that it crosses the macula, goes on to the other side. Again, of course not, it's unknown. It can happen, but very rarely. Usually it's on the same side. So this is a case of papilledema where you can see the severe involvement of the disc. The rest of the retinal is looking normal. As you go away, you start seeing normal looking vessels. This is a pseudo papilledema. Again, although the vessels are kind of rising up and going down, you can see there's absolutely no cup, and the vessels per se are seen quite clearly. So, of course, that patient had hypertension, controlled blood pressure, look for secondary causes. Unilateral disc edema, 25-year-old female presented with sudden unilateral loss of vision. Left eye, you can see vision is poor. There was an RAPD. You can see that there is a fair amount of unilateral disc edema in this patient. You would, in the normal course, fit into a case of left papillitis. Typical optic neuritis is the diagnosis in this patient at the moment. Typical optic neuritis, as was defined by ONTT, would be uniocular, vision functional loss. So it's a visual function loss. Remember, any one of the visual functions can be affected. Patient may just come with a visual field effect and have 6/6 vision, or may have very, very severe visual acuity effect. So any of the visual functions can be affected. They may come with just color desaturation. They may just tell you that from one eye the colors are not looking as good as the other eye or as they used to. Usually painful. So you have moderate amount of pain, especially on eye movements. The visual loss, as I said, can be subtle to complete. Peak vision loss occurs by 2 weeks. Subsequently will stabilize and start improving. Presence of RAPD in unilateral cases and papillitis are normal in RBN. Just to tell you, you can see this previous disc that was there. The edema is there, but it's nothing compared to what you see in papilledema. So in established case, if the vision is less, because of papilledema, you're going to see adequately swollen discs, and they're not going to look like this. They're going to look quite characteristically sitting there with a lot of fluid. So swelling of the disc is much less in papilledema. Causes are a lot. We've discussed about the image findings and all, but multiple sclerosis you suspect the moment you start seeing changes on the MRI. Optic neuritis presents in 50% of the patients with MS during the course of the disease, presenting feature in 20 to 30% in different studies, and recurrent involvement of the same of the fellow eye. The other thing to take back also is atypical optic neuritis. A lot of patients do not fit into this very classical appearance of optic neuritis, and you can have painless loss, older patients, bilateral, severe edemas, hemorrhages and clots, corneal spots, recurrent episodes. So whenever there are these features, it's atypical optic neuritis. This typical atypical is just a clinical classification telling us that if it's typical,
it's likely to be demyelinating. Think about demyelination as a cause as isolated optic neuritis or in association with multiple sclerosis. If it is atypical, it is very less likely to be demyelinating, not impossible, less likely. So think of other things like compression, infection, tumors, all kinds of other causes that may be responsible for the atypical presentation along with disc swelling. So typical, isolated, MS associated, atypical, you have a whole lot of conditions, the most important being NMO spectrum disorders, MOG positive patients. So these are important things, autoimmune. So these are the vast diagnoses that we see whenever we are looking at an atypical presentation. Imaging, one would say that every patient of optic neuritis or unilateral or bilateral disc edema requires an MRI, brain and orbits with contrast as a minimum, because you cannot really pick up anything without that. It helps us to rule out a space occupying lesion and identifies demyelination, something which a CT cannot. We've talked about the protocols that you require. If in doubt, just write an MS protocol. A radiologist is well aware of what an MS protocol consists of. You need flare for brain and fat suppression for orbits. So these are key things. Otherwise, as Dr. Monica pointed out, you just can't pick up the subtle findings that are there in the imaging. When in doubt, always give as much information to the radiologist who's going to image of what and where you expect the lesion to be. And like I said, MRI of all patients, but it's definitely mandatory in recurrent optic neuritis, patients who want to know whether they have MS or not. And now with Lord Google as the greatest source of information in the world, all patients come with this information and understanding that there's something called multiple sclerosis. Patients with a history of or evidence of other neurological involvement. So any past, even suspicion of say tingling in the feet or sometimes occasional numbness should be considered a neurological event and examined in detail. Atypical cases and acute optic neuritis in children. So these become our key things. Images of course we have seen. Management, optic neuritis, demyelinating, actually you could probably say no treatment provided you are absolutely sure it is MS related or demyelination. Otherwise, although ANTT said this as an option, one would say that the increasing incidence of NMO spectrum disorders, I would really not be willing to consider no treatment as a possible option for patients unless it's steroids are contraindicated, like the patient is pregnant or some other reasons because of that. IV methylprednisolone is the intervention of choice. Oral steroids are contraindicated in demyelination. They have been shown to increase the recurrence. So it's very, very important to know that. Of course, interferons or any other therapy can be done in association with the neurologist, but first intervention as an ophthalmologist should be IV methylprednisolone. Another case of disc edema, 40-year-old female, diminution of vision right eye 1 month, hand movements, RAPD, you can see the fundus. So here you can see 1 month becomes the atypical feature and I start thinking of something else. So rule out infective inflammatory causes. The spine was discussed. You can see the involvement of the spine in this patient. A serum NMO was done, which was positive. So this patient was an NMOSD optic neuritis and was treated in conjunction with a neurologist. Now, because most of these investigations take time, including imaging for often, and of course serum antibody testing takes a week at least in the best of centers. MRI, that's why becomes our first most important investigation for us to give an idea what we are doing. So if there are signs suggestive of MS, you're thinking of MS, IV methylprednisolone, patient improves, start following up the patient. Patient does not improve or the images are not suggestive of multiple sclerosis or there are involvement in other areas of the brain including spinal cord, think in terms of NMO, because aggression in treatment in NMO is very, very important. You give methylprednisolone, discuss with the neurologist. If the vision does not improve, the patient may be required to undergo plasmapheresis and a lot of other interventions. The other important reason for differentiating these two is that disease modifying agents which have a role to play in preventing the onset and progression of multiple sclerosis are contraindicated in NMO and NMO spectrum disorder because they be found to worsen the disease. So it's very, very important for you to know this differentiation and have a subtle identification of what exactly this patient is. We go on to unilateral edema. So we've kind of covered bilateral hyperemic disc. We talk about pale disc edema, 56-year-old diabetic patient, sudden loss of vision. You can see subnormal vision, RAPD. You can see edema. Again, initial period, even in NAION, the hyperemia may not necessarily be pale. So it may be initially a little hyperemic to start with, and then pallor can set in. Altitudinal field effects, more often we see inferior, so non-arthritic ischemic optic neuropathy was the diagnosis. We've talked about a whole lot of risk factors: diabetes, hypertension, the two most common, coronary artery disease, hyperlipidemia, something increasingly has been known to be associated, although considering the Indian diet, a lot of us are hyperlipidemic, but again, it's an important thing that requires intervention and control. Sleep apnea, nocturnal hypotension. Now, that's one of the things in hypertensive patients. They take their anti-hypertensive medication late into the night, especially beta blockers. That results in early morning hypotension, which is a risk factor for development of NAION. So it's very, very important to discuss with them that if required, they switch from a beta blocker to some other antihypertensives, and also not to take their antihypertensives very late into the night. Smaller cups, disc at risk as was presented, hypocoagulopathies, anemia, blood loss, migraine, smoking. Management in NAION is control risk factors. Everything else has not had any proven evidence, including steroids. And in the study that we did from here, we found that while disc edema, the edema resolves much faster than the group that was not treated. Finally, there was no significant difference in the visual outcome. So severe edema you may think of, but please remember, only try in non-diabetic patients. In patients who are diabetes, or diabetes is actually a cause, possible potential cause for development of NAION, I personally think it is definitely unjustified to treat a patient of diabetes with what you are considering as the etiology of the disease. So I would say the treatment in this condition is actually worse than the disease that the patient had. Another 76-year-old male patient, sudden painless loss of vision, one eye followed by the other. These are important histories. So any patient who comes, especially a little older, these are the things you need to ask for: jaw claudication, scalp pain, headaches, muscle pain, and of course vision was affected in this patient. You can see the kind of appearance: chalky white swelling, retinal edema. You can see that the disc is absolutely, the whole disc is involved, and a lot of region from adjacent to that on both the eyes are involved. The other investigation that needs to be done is ESR and CRP, both of it was elevated. The patient had arthritic ischemic optic neuropathy, very rare thankfully in the Indian circumstances. We don't see them pretty often, very, very rare considering the frequency in the West, but it is still not unknown. So it's important because it's an emergency. If one patient comes with one eye involvement, more than anything to do with this eye, we are trying to protect the other eye and make the patient go blind. FA, of course, not again ever indicated anymore, but just to show you, decreased choroidal circulation is what you see in them. Consider GCA or arthritic if advanced stage, headache, scalp tenderness, jaw claudication, muscle fatigue, weight loss, transient visual obscurations, diplopia, bilateral involvement, retinal choroidal ischemia. So these are very big red flags for an ischemic neuropathy that you must know. It's an emergency because you need to prevent blindness. High dose steroids, oral, I still don't see an indication for IV in them. I would say oral, immediate start oral steroids. You may require to continue them for a very long period of time, probably a year or two, and you taper them with the ESR CRP. These are differences which I think were discussed earlier. Just to show you, this patient came with a little bit of disc pallor, and that's about it. We thought of it NAION because you can see that slight pallor here. So one part of the disc is looking more pale than the other. See the field, very small area involved. Patient just came with a little bit of moderate visual loss and nothing else, and the field was like this. So any part of the disc can be involved in ischemic optic neuropathy. Diffusion weighted imaging was discussed. Just it's a very early role in NAION or in arthritic ischemic optic neuropathy. You can see studies have said that they can use ADC maps to actually identify acute ischemia in these cases. It's important because now our differentiation with neuritis is getting a little blurred. Earlier we used to have very clear understanding that younger patient, neuritis, 40 above, ischemia, start considering ischemia, but now we know because of NMO, this difference has started getting blurred. We get first episode of neuritis because of NMO even in an older patient of 40 plus. So that's why probably we need more and more investigations to help us differentiate when clinically we cannot. So this was about disc edema and a variety of cases that we had put together for you. Dr. Swati, who is actually now doing a lot more neuro-ophthalmology than I am, has huge experience in neuro-ophthalmological conditions with a lot of research under her belt, although she's wearing a sari. We'll be talking about disc pallor and running us through with some cases of pale disc.
Thank you, sir, for that introduction. I'm just building on the platform that you gave to me. So I hope I am able to carry it forward. So I would be discussing the cases related to this pallor, different presentations, and how we can differentiate, do important investigation and reach to a diagnosis. So as said earlier also, this pallor itself is not a disease. It's just a manifestation of a disease. And as Dr. Priyanka has already classified, it can present as a secondary optic atrophy or a primary optic atrophy. Now, secondary optic atrophy is just an extension of disc edema. So all those conditions which present as disc edema eventually in later stage will have secondary optic atrophy. So I'll not be concentrating more on it. Why? Because it has already been discussed in disc edemas. So this presentation will actually cover the primary optic atrophy, which is much more confusing. And you know, we all get kind of flustered whenever this kind of disc pallor comes to us, as what investigations have to be done, how do we proceed, and how do we finally treat. So there are certain causes of primary optic atrophy depending on the fact whether they are unilateral or bilateral, and the idea of this presentation is to tell you those subtle signs in clinical examination are relevant in the investigations that may help us to finally diagnose the case. So this particular patient, a 24-year-old male who currently presented with subacute loss of vision in both the eyes. On examination, the vision was 612, which is not very bad. Pupils are not poorly reacting. They are more or less normal only. But the color vision is severely affected. So if you have this kind of presentation with discs which are like, you know, temporal pallor on both the sides. So what's the first differential you have? So, sorry? LHON? Yeah, maybe that is a possibility that needs to be considered. So, but you can see that the vision is very nicely preserved. It's around 612. LHON generally has a poorer vision. So moving further, this is the, you know, these are the field effects. So both eyes are showing central scotomas or centrocecal scotomas for that matter. So your differential now narrow down that it is limited to optic nerve, right? It's not moving beyond optic nerve. So it's optic neuritis, is it? Because pupils are normal, so probably you can rule out optic neuritis. LH1, as I said, the vision is relatively better. So just a simple question in history can give you an answer. So he has a history of use of ATT. So color vision loss is probably the first symptom in such cases. You must always, so it takes just one simple question to ask. I keep on reasserting this in my clinic to my students. Just take a proper history. So just one question. Even for that matter, physicians who are treating these patients, treating patients of tuberculosis should ask only one question. Is your color vision all right? Is your vision not deteriorating? So these are only two questions that you need to ask to diagnose this kind of patient, right? So generally it is seen around 2 to 5 months of use of ethambutol, and it is a dose dependent. So normally recommended dose is around 15 milligram per kg body weight. So at this dose, the incidence is around 1%. As we increase the dose, the incidence moves to 3% and then maybe later up to 5%, depending whether you're giving 25 milligram or 30 milligram. So WHO has now fixed a criteria to around 15 to 20 milligram as a safe dose for the ethambutol, and also has revised the guidelines for treating the tuberculosis. So using ethambutol in tuberculosis. So ethambutol, which was earlier used only for initial 2 months in intensive phase, is now also used in continuation phase, but is used in a safe dose window. So it's usually bilateral symmetrical. So that's one major clue: bilateral symmetrical. Gradual onset. So no, it's not that there will be a sudden loss of vision, there will be gradual loss in vision. Central centrocecal scleromas are commonly reported, but at times you may have bitemporal field loss in ethambutol toxicity also. As I emphasized, color vision deficit is the most common symptom and the first problem to come up. And generally 50% patients may show some kind of recovery, partial recovery, but many patients will not show any recovery. So that you have to keep in mind. So it's important to pick them. The treatment is in the form so before we move on to treatment, the pathogenesis, because ethambutol is known to have a copper chelation, iron chelation and zinc chelation, it disrupts the oxidative phosphorylation and increases the reactive oxygen species, which eventually leads to apoptosis of ganglion cells. So that is the basic pathogenesis. As far as treatment is concerned, there is no major treatment and we have to stop the ethambutol. That's the first thing. Number 2, give the vitamin B12 supplements that may help. You may give zinc supplements also that may help. And recovery takes time. So it's not that you have stopped the treatment now and from 1 month or 2 months afterwards you can see the recovery. No, it may take as much as 6 months also to show some kind of recovery there. And yes, the recovery, as I said, may not be complete. So this is a study which we had done in our center. We found out that even though there may not be a clinical evidence of toxicity of ethambutol in cases of pulmonary tuberculosis, where there are category 1 patients where they are treated only for 6 months, but these patients may still show subclinical toxicity in form of decreased GC-IPL thickness, also in form of changes on VER, as in form of increased latency. So you have to be careful whenever these kind of patients present to us. We need to investigate and make them aware. The important thing is awareness. So this is a case to a 20-year-old female complained with diminution vision, no pain, no other history. On ophthalmic examination, she had 4/60 and 6/60 vision. Pupil were again normal. And this is the kind of dish she has. So any idea that, as you see, there is a pallor on both the sides, the temporal pallor. What could be the differential again? Methanol toxicity? Female patient? That's the first thing. Right. So
let's not make gender-based statements. There is an equality that we expect in all aspects of our life.
Yes, equality is there in drinking also. So female patient will generally drink a quality drink. So this is what it is. So you have here temporal pallor on both the sides. So what I'm trying to emphasize that look the fundus in entity. Just don't go by disc. Just don't get overwhelmed by disc pallor, right? So this is a classical case of consecutive optic atrophy where you have retinal lesions. It could be any macular dystrophies or maybe a variant of RP, also central RP. You can see their pigmentary changes, although arteries generally look okay. Here it is the only artery which seems to be narrow, constricted. But it could be a macular dystrophy or a variant of RP. But what I'm trying to emphasize is it's important to look fundus in total, right? So that's what it is. Thorough fundus examination is all you need to diagnose this pallor. So case 3, a 40-year-old female complaining of nausea, vomiting 1 month back. So this is a male patient now who is complaining of nausea and vomiting 1 month back with sudden loss of vision in both eyes after a day. No history of pain, no other history of systemic illness. On ophthalmic examination, he has a severe, profound vision loss, as bad as PL negative and PR inaccurate, and pupil are not at all reacting, they are fixed, dilated. This is the fundus examination. So what you can see here, they are pale disc and with enlarged cupping. So it's quite a big cup, near total cupping in both the eyes, with a normal pressures over here. So again, your differentials are? That seems to be favorite among residents. So the another case, I'll come to it. Let's take this one more case, a 42-year-old male who presented with again loss of vision for few months and difficulty in driving. He had a history of hypertension and was treated outside with anti-glaucoma medications. His vision was relatively okay. He didn't have poor vision as compared to the previous case where the vision was very, very poor. Again, here the pupil are normal. It's not, there's no RAPT, the reactions are normal, and you can see the cup is again increased with temporal disc pallor on both the sides. So if we take two cases, what's the diagnosis and how will you proceed for investigations? Yeah, I'm coming to that. So now look at it. When the vision is poor and the pupil are affected, you are probably dealing with an optic nerve pathology. While the vision is relatively maintained in early stage and pupil are normal, you are dealing with visual pathway pathology. So that's one way of localizing things. So we went ahead, case 4, we did this investigation. This is what we found. We found that there's a bitemporal hemianopia. On OCT also we found that there was RNFL loss and GCL loss, and this was a CT scan. No lesion over here, but that's not the right thing to do. The important thing to do is to do a MRI, which will give you a lesion. So it's not just important to know what is the diagnosis, not just important to know what investigation, also important to know how it has to be ordered, which investigation has to be ordered. So this is an MRI showing a huge cellular mass over there, suggestive of pituitary adenoma. Coming to case 3, now if you go back, he has a history of nausea, vomiting, followed by a sudden loss of vision. And now, yes, as you rightly pointed out, he has a history of ingestion of adulterated alcohol, suggestive of methanol toxicity. So many of them will not come up with this kind of history in first go. If you ask them, they said, "Nahi, I don't drink, I don't smoke." So all these kind of things are there. You have to keep on probing them over and over again and understand whether there is any history of such kind of ingestion or not. Okay, sorry. So whenever there is a pallor more than cupping, or pallor which is equivalent to cupping, or pallor which does not look as a glaucomatous, huge cup but equally importantly significant pallor, your differential becomes compressive optic neuropathy, methyl alcohol poisoning, and of course normal tension glaucoma, which is a diagnosis of exclusion, right? So case 5, this is a 35-year-old male with a gradual loss of vision in one eye for 1 year, associated with dull headache. There is history of rhinitis, there is history of nasal discharge and mild fever on and off for 1 year, which gets relieved with medication. So this is the ophthalmic examination. His left eye has poor vision, but right eye has good vision. There is left RAPT, and this is what is the fundus picture. So this is a classic picture of secondary optic atrophy. You can see there's a lot of gliosis over margins are not so well defined, and there is this vascular vessels also show some kind of sheathing and gliosis over there. So on examination, it's important to do a complete examination. You can see there's some fullness over here, frontal swelling, a cystic swelling over here, and it's giving a nasal discharge on compression, and probably doing a relevant CT scan here to look for bony erosions to rule out any tubercular related abscess or granulomas over there may help. So this is what we got. We got a frontoethmoidal mucocele. So if you have a lesion which is anterior to the optic canal, presenting anterior to in the anterior orbit, what compression will cause disc edema. But if you have a compression which is at the optic canal and beyond that, it will present as this pallor. pallor. So that's the thing you need to understand, how the compressive optic neuropathy will present. Also, if you have the optic nerve involvement, compressing optic nerve, you will have a afferent defect, pupil afferent defect, and you will also have vision loss. But if you have a lesion which is compressing beyond the optic nerve, you will have field loss, exactly, and pupillary afferent defects may not be there. Then case 6, this is a 17-year-old male with sudden bilateral painless loss of vision for 3 months with no other history. So on examination, this is what is the vision: 5/16 one eye, 3/16 another eye, left eye. Then sluggishly reacting pupil, and on VER flash, both the eyes, the latency is increased. And this is his fundus picture, again a temporal disc pallor. Now what will you do? Demyelinating lesion. How? Yeah, similar age, number 1, good. And if it is demyelinating, of course it will show some kind of improvement, right? Demyelinating lesions show some, even if not complete, partial improvement can be seen commonly. So we went ahead, did RNFL OCT, did GCL IPL OCT. You can see that the RNFL OCT shows RNFL loss, but it is GCL IPL which is showing much more severe loss, right? Now the diagnosis becomes Leber's, right? So Leber's hereditary optic neuropathy is basically a mitochondrial disorder. It is inherited by maternal transmission and therefore is seen in males and not so commonly in females. Females are carriers. It can manifest in females, but very, very rarely. So if you have a female, if you have to make a diagnosis of LHON, in females you have to think not twice, probably multiple times. And the most common mutation is 11778, which is seen in around 70% of cases with the poorest visual recovery. The best visual recovery is seen in 14484C mutation. So basic pathology is the decreased ATP1 production, decreased complex 1 leading to decreased ATP production and increase in free radicals. So it shares its pathogenesis with the toxic optic neuropathies. So more or less the pathogenesis is same as that in toxic optic neuropathies. As far as treatment option is concerned, you can give there are multiple treatments like vitamins, cofactors, although none of them have shown a very promising results. Itibinon is still being tried. There is genetic therapy has also come up for Leber's, but none of them are shown very promising results in Leber's optic neuropathy. More important is to avoid the triggers that may precipitate this disease, like drinking, smoking, exposure to poisons. Certain medications like ethambutol, chloramphenicol, linezolide may precipitate this disease. So that's more important to know. So another case, this is a 15-year-old male complaining with gradual progressive loss of vision in both eye. Right eye has 2/60, left eye has 1/60. Now please notice the pupil reactions are again normal, right? So this is the fundus picture. Sorry? So right eye you can see there is severe disc pallor. I think I'm sorry, I've put this photos ulta. Yeah. So this is the waveform. So I just wanted to emphasize the role of electrophysiology, where they can help how you can proceed for the investigations. You can see that the photopic waveform is almost extinguished, while scotopic waveform is good. It's maintained. So it's probably a case of cone rod dystrophy. Okay. So this is a 25-year-old male, history of road traffic accident. One eye shows severe vision loss with RAPT and other eye is absolutely normal. I don't think it requires any rocket science to diagnose this case. This is a clear-cut case of traumatic optic neuropathy. But what I do want to emphasize that you must understand the severity of trauma. It's not just any kind of trivial trauma is going to cause traumatic optic neuropathy. The trauma has to be severe enough to cause the disruption of optic nerve, and it can be a direct when there is a direct anatomical disruption of optic nerve, as in form of optic nerve avulsion, optic sheath hematoma, or if the force is transmitted to the if the force is so severe that it transmits and causes the fracture of optic canal over here, then that is the kind of force, that is the kind of trauma, that is the severity of trauma that's required to cause a traumatic optic neuropathy. Right? And indirect pathology, indirect pathophysiology is something, you know, where the optic nerve is a fixed structure at its quite fixed at its optic canal, while the globe is moving. So there is a shearing force between the globe and the nerve, which leads to the coop countercoop injuries and leads to the shearing of retinal ganglion cells and ultimately poor vision. So that's an indirect injury. Right? So management still remains controversial. We don't know what exactly is the management and how to proceed. All sorts of management therapy, whether it's steroids, whether it's surgical decompression, or whether it's any other form, have not shown to give any good results as far as traumatic optic neuropathy is concerned. And the baseline vision is the most important prognostication factor that will tell us whether this patient is going to improve or not. So as I would like to conclude, optic neuropathy, whether it is disc edema or disc pallor, you have to differentiate where one, it is unilateral or bilateral. Then you have to differentiate whether the vision loss is rapid onset or gradual onset. So these are the differentials. If you have unilateral, rapid onset, visual loss causes, these are the differentials when you have bilateral, gradual onset vision loss, suggesting of compression, toxic and nutritional and hereditary. Thank you.
Thank you, Dr. Swati. Excellently covered a very interesting series of cases. So, before we move on to change gears to motility defects in pupil, we could take a couple of questions, if any, while Dr. Rebecca, our very dynamic and young faculty with us, again with a lot of work on neuro-ophthalmological disorders, would be talking about decoding diplopia. So, any questions we wanted to? Yeah, Dr. Amrita, please. So, so we see a fair amount of atypicality. Actually, probably also because patients come to us referred. So, as a tertiary care center, they get referred to us far more frequently when they don't resolve or they have features which are not classically. So, as a percentage-wise, I would say that we see a far higher percentage of atypical presentations as compared to what we would have considered as typical optic neuritis. So, sitting in a tertiary care center, it would be very difficult for us to give an opinion on that. I would say that sitting here, I would have really thought so. But if you review any of the large literature that has been done or surveys done in India, they've generally talked about at least NMO positivity to be about 10 or between 10 to 20%. So I would, in the West, where there is far better information on that, they place it less than 10%. So they have it 5 to 10%. And I would say that our experience in India has been that NMO is much larger. And that's why probably in the initial first few years of the century, we used to quite not understand what's going in our patients of optic neuritis, and we used to find them behaving a little differently from what ONTT used to say they should behave. And unfortunately, the patients hadn't read the ONTT, so they didn't know how to behave. So we used to see a lot of different presentations from optic neuritis typical, and probably looking back, it's because even then we used to see a lot of atypical presentations, possibly because of NMO and all, and we used to think probably it's infectious or something. So I would not really say that it's increasing. Maybe we are picking up more. The other thing, of course, is that COVID has changed a little, because probably because of the increased reactivity that you see because of COVID. A lot of autoimmune related or NMO related patients who would not have maybe clinically triggered the event got triggered because of COVID. So that's again just a hypothesis based on our understanding of the COVID and its manifestations. But we see a fair amount of atypical presentations. We see a lot of patients who don't improve. But I would not say that that is necessarily true for the entire Indian population. I would say that We are seeing it more selectively. Yes, we have a much larger percentage of atypicality, probably because of NMO, infections and inflammatory disorders. But again, we still need more hard data to be able to say that. Yeah.
Sir, have you seen more incidents of COVID-associated optic neuropathies in the patients who have recovered or have been given interferon or something like that?
So again, it's a little difficult to put these two things absolutely together. Temporal associations and getting a history of COVID, or even in one or two patients a history of vaccination, we believe, and they come to us or present to us with optic neuritis in its typical or atypical form. It's again, like I said, it's convenient to jump to the conclusion that it's COVID related. But again, a lot of hypothesis that has gone into the fact that why we are seeing a little, we saw, thankfully now we're not, we saw especially after the second wave or even after the first wave, a fairly larger jump, was probably that COVID and the vaccination increases the immune response. So again, patients who probably on its own may not have had the event, the acute event, because they had very low levels of circulating antibodies or low risk, suddenly become high risk, and therefore a larger percentage presented to us. So I would not say it's like COVID because of COVID per se, but yeah, because of the conditions there that happened, probably we saw. We're still understanding the disease, the manifestations, to be able to give a more direct association of the disease.
So the second question was the slide that you showed. Can it be venous stasis retinopathy, which we thought that a 40-year-old, no systemic history, because even if it would have been hypertensive retinopathy, there would be having vessel signs there.
The patient who hypertensive retinopathy, which I have differentiated, but the patient had very clear hypertension. It resolved with blood pressure,
so
and again for venous stasis, you would have to have a lot of tortuosity of the veins, and you would see that sluggish flow of the venous.
So actually, it was written that no systemic history was there.
So history was not there. So the patient had no history, but he turned out to be hypertensive, something that is unfortunately true for a large bulk of patients coming to us.
Okay, thank you.
Yes, ma'am.
It's about systemic optic neuropathy.
The VP, the characteristics, that latency is normal and the amplitude gets reduced. Can it be used more often as a diagnostic criteria when we have a patient suspected of this? Because many patients now with risk factors are presenting as optic, papillitis or this thing. And sitting in a clinical practice, it becomes so difficult to actually find out the cause. We run all the battery of tests and find out there's nothing. Maybe it was just an ischemic. So why not to begin with, we have this simple test done and reach to maybe it might help us.
So there are two rate limiting things in this thought process. Very interesting, definitely. The two rate limiting things are, one, that the investigation has to be very robust and adequately differentiating the two diseases. Firstly, unfortunately, we don't have access to that good, experienced persons who can do a good VP and give us good quality data. We don't have also good quality data as to what is really the normative values. We are always using Western normative data. So for it to be diagnostic, I would think it requires a lot more work. The second thing is, while it's simplistic to say that amplitude decreases, latency does not increase, but these are what is typically we see, or broadly, but over time you will see that even the latency will increase over time. Even in severely affected neuritis, the amplitude would decrease. In fact, sometimes with very severely affected optic nerve in its acute phase, you may not get a very reasonable waveform, and what values you are getting are more of kind of impressions of the waveform that the person conducting the test is giving you. So the waveforms or the positive negative waves are not so robust for you to be able to actually pinpoint their peak and their trough. So that is why interesting, definitely, when we don't know exactly those clinical conditions where there is not clarity as to what we are dealing with, we would tend to err on the side of considering the disease to be more treatable, as in a sense that considering it to be neuritis where I could do something, unless it's contraindicated, like I said, if it's like, frank diabetes, than to think in terms of an ischemic event. But that would be, on a case-to-case basis. But yes, an interesting thought. Some of these cases may help by doing a more finely focused investigation, including VEP. And I think electrophysiology is unfortunately even now underutilized in optic nerve disorders.
If I may say something, ma'am, because ischemic optic neuropathies are now kind of overlapping with MOG-associated optic neuritis. So there is the line is blurred between the two, and I think it's important to investigate patients specifically if they are presenting bilaterally. Unilaterally, you may still think that probably it's a non-arthritic ischemic optic neuropathies, but if it's a bilateral presentation, we have to look into that whether it could be a MOG-associated optic neuritis or not. Because the age group, as we have said, what we used to believe that the younger patients have optic neuritis and older patients do not, is that doesn't hold true anymore. A lot of these patients are 40 plus also, MOG patients and NMO patients as well. So if you have such kind of a confusion, especially if it's a bilateral, it's better to go for neuroimaging and look at nerves and see whether there is any enhancement or not. Also do a serology for MOG antibodies.
So I think let's move on to yeah. Okay, we'll take one last question.
I have a question. Actually, basically jaw claudication, how can you differentiate? It is because of TMJ disorder or because of optic nerve disorders?
So the jaw claudication is just a systemic manifestation of what is happening in the optic nerve, in the vascular supply of the short posterior ciliary arteries and veins, the medium and small vessels getting affected, and that's what is happening. It's getting affected all over the body, and that's why in arthritic ischemic optic neuropathy we actually talk of 5-year survival rates, because many of these patients actually go on and lose their lives because of involvement in the heart and brain. Jaw claudication, of course, if you have an obvious TM joint anomaly, you obviously will not take that history seriously, and you would consider other clinical features and history and examination, and of course ESR CRP, irrespective of the clinical presentation, would be my most important guiding and diagnosing investigation. So obviously any history you get, even like I said, temporal headaches, you need to examine for the temporal artery and see for its nodularity, thickening. Otherwise, as I said, headache is such a common symptom all of us present that it's not always easy to use these as a diagnosis.
So I think moving ahead with the session now, since it's
Sir, one question.
Let's take it little by little. Let's go on and let's complete, because there'll be a lot of motility related and pupil related and very interesting discussions, and let's complete them. Dr. Rebecca, like I said, and very enthusiastic and very good neuro-ophthalmologist amidst us. She'll be talking about decoding diplopia.
Thank you, sir. Now it's already afternoon, so before we hear the stomach cramps, we would like to quickly go through these other important topics that we have. So it's basically the binocular diplopia. So when a case of diplopia walks in, the first thing that you should decipher is whether it's a monocular or a uniocular binocular diplopia. Because it will save a lot of your investigations and a lot of unnecessary referrals. So how do you do it? Just cover one eye of the patient. And if the diplopia persists, it's obviously monocular. And it is mostly related to your anterior segment problems like astigmatism or cataract, etc. And if it disappears when you cover one eye, then it's a binocular diplopia, and this is the one that we are mostly concerned about, and you would want to investigate further. So what is diplopia? Well, it's derived from two Greek words, diplus meaning double, ops meaning the eye, and it occurs because of the misalignment of the two eyes. So for one physical image, you are seeing two physiological images, and the cause may actually vary from a very simple benign condition to a severe life-threatening condition. The causes, as I told you, it could be neurogenic or it could be myogenic. So neurogenic causes could range from supranuclear, nuclear or infranuclear. And myogenic could be nerve muscle junction disorders or muscular. Now remember that not all supranuclear disorders will cause a diplopia because most of them have a conjugate paresis. But some of them like iron and all can present with a diplopia. But the major bulk is caused by your 3rd, 4th and 6th nerve palsy, which are your extraocular muscle palsies. Now basic workup, I think a lot has been discussed about the workup in neuro-ophthalmology. But just remember that in diplopia, just see what type of diplopia, horizontal, vertical, torsional, whether it's worse for near or distance. A diplopia which is worse for distance, it could be a 6th nerve paresis. Diplopia mostly is maximum in the gaze of the affected paretic muscle. And look for other associated symptoms like if you see this proptosis or some decrease in vision, you know that the pathology is lying somewhere here in the orbit. But if you see some neurological signs like headache or seizures, you can localize the pathology somewhere in the brain. So this is, I think, a basic thing that all paralytic squints should undergo this workup. That is your check for vision, pupils, head posture, extraocular movements, and your Hesley's charting, diplopia charting, FDT. Now FDT helps you rule out whether it's a restrictive squint or not. If there's a vertical tropia, so remember you can do the Sparks 3-step test by which you can identify which of the cyclovertical muscles is involved. So this is just a part of the basic workup. Now based on your clinical evaluation, you make a clinical diagnosis and your work is not just yet over. So next thing is you need to identify the cause. So depending upon what is the age of the patient, what you are suspecting in that patient, you can do laboratory investigations, but the most important thing is neuroimaging. What type of neuroimaging, it has already been discussed, okay? Lumbar puncture may be needed in specific conditions, like if you're suspecting meningitis or raised intracranial pressures like idiopathic intracranial hypertension, etc. Based on this, you finally identify the cause, you have to treat the cause or refer the patient for the management of the same. Meanwhile, for diplopia, you have to treat the patients with patching, prisms or the botulinum toxin. So this toxin could be injected in the antagonist muscle and keep the patient under close follow-up. Now I will be doing these case-based discussions. So first is the supranuclear disorder. So remember, even though they were not present with the diplopia, but I'm just still discussing them just to cover the list of motility disorders. Now this is an interesting case. A young female patient comes to us and look at the movements. Horizontal gazes, you see? The horizontal gazes on either side are affected. And what about the vertical gaze? The vertical gaze is relatively intact. So the vertical gazes are intact, but the horizontal gazes are affected. And the convergence was found to be normal in the patient. She also had a bilateral facial palsy. It was actually left more than right. So this was a case of a horizontal gaze palsy with the facial nerve involvement. So you have the horizontal gaze center and the facial nerve involvement. And these two are present together where? In the pons. Yeah, so you would suspect something in the brainstem. So that is what we found. There was a huge pons angioma, So the clinical signs are giving you the topographical location of the lesion. So just brushing up the anatomy. So this is your pons. You have the PPRF here. That's the horizontal gaze center. And it is in close association with your 7th nucleus and the 6th nerve and 7th nerve. So any pontine lesion can affect any of these structures. Now another case. A young male patient. Now look at what is happening in the levo version. You see there's a limitation of adduction in the right eye and there is an abducting nystagmus in the left eye. Yeah, absolutely. That's a case of INO. That's very classical, So this would indicate the lesion is there in the medial longitudinal fasciculus. And MLF could be there in the brainstem because it extends from the pons up to the midbrain. So we found this pontine lesion here. There was a pontine infarct, a small infarct. So it was a... Now another middle-aged male. You see the eyes are well aligned in primary position. Up gaze are intact. Now look at the levo version. There is a left gaze palsy. Look at dextro version. You see a limitation of adduction and there was an abduction nystagmus here also. So what do you see? It's actually a combination of left gaze palsy and a left INO. So exactly. So that becomes a 1.5 syndrome. So again, you are suspecting some big lesion which has affected both these structures. You get a neuroimaging and this is what we found. a large heterogeneously enhancing space occupying lesion in the brainstem. It was compressing the brainstem. Most likely it was metastatic, so a PET scan was done and we found that the primary lesion was there in the kidney. So you see the patient comes to you with some ocular complaint and you eventually diagnose as some life-threatening condition. So that is what a role of neuro-ophthalmologist or as an ophthalmologist would be, to diagnose these cases early and refer them on time. So just to brush up this pathway, you have this PPRF. Look at the sagittal view because this will give you an idea. PPRF is here in the pons, sends the impulses to the abducent nucleus ipsilaterally. From here, the abducent nucleus is sending impulses to the ipsilateral lateral rectus muscle and to the contralateral medial rectus. And how does it do that to the contralateral side? Via this white matter tract, which is your MLF. So MLF is this purple rod which is going all the way from the pons to the midbrain. Okay? So if anything happens in the MLF, it's causing internuclear ophthalmoplegia, and if a huge lesion is affecting both these structures, PPRF and MLF, it causes a 1.5 syndrome. Now another interesting case, it's a child aligned in primary position, but look at it, you see there is a bilateral superior oblique underaction. So it's a bilateral superior oblique palsy, and the up gaze is limited. Also have a look at the video. So on the gazes, you see that the inferior oblique overactions are evident. So inferior oblique overaction is why? Because there's a superior oblique palsy. But look what's happening in the up gaze. In the up gaze, you see this convergence retraction nystagmus. So there is a limitation of up gaze with a convergence retraction nystagmus. So it's a case of? Absolutely. So this tells you that again you have to image the brainstem. So we did this, we found obstructive hydrocephalus, and this was a huge cyst that was causing this in the fourth ventricle. We immediately referred the patient to neurosurgery. The neurosurgery people preoperatively repeated the scan and they found that the cyst had migrated to the third ventricle. So it was a live intraventricular cysticercus that had caused the obstructive hydrocephalus, and this was presenting as dorsal midbrain syndrome as well as bilateral superior oblique palsy. So just in brief, your vertical gaze center is present where? It's the rostro-interstitial nucleus of MLF. Now up gaze neurons are passing on the lateral aspect of MLF, they decussate in posterior commissure. Now since anything happens in posterior commissure, it can cause a dorsal midbrain syndrome. So just remember these features, you can go back and read about it, the other features of the syndrome. And a common cause that has been noted in children is hydrocephalus. And mostly it's aqueductal stenosis, rarely cysticercus as was seen in our case. So why does a hydrocephalus cause this dorsal midbrain syndrome? Because see this structure over here, that's your posterior commissure, this thing. So here, so this you see. So if there is a dilatation, this gets stretched. So when this gets stretched, it causes the your dorsal midbrain features. Now coming to the infranuclear. So we are done with most of the array of your supranuclear disorders. Now coming to the infranuclear. Now this is the bulk of your binocular diplopia cases. So remember this anatomy. I'll not be going into the detail. So you should know that the third nerve nucleus is present. It's in the midbrain. In the fascicular part, it's associated with important structures which is red nucleus and cerebral peduncles. In the subarachnoid space, it has association with these important vessels. So, if you have the knowledge of this anatomy, you can actually localize where the possible lesion could be in case of a palsy. So, this nuclear complex, you should know that LPS is a single unpaired nucleus and it supplies the bilateral LPS muscles. And superior rectus subnuclei, it supplies the contralateral superior rectus. So, if there is a nuclear involvement, remember that you will have a bilateral ptosis and a contralateral superior rectus weakness. If there is a fascicular involvement, as I told you, fascicles, they are present, they are associated with your brainstem structures, you will have these brainstem signs like hemiparesis, tremors, etc. If it is your subarachnoid space, that means the basilar part, the involvement is typically isolated. But this is actually the most dangerous area of involvement because of the association with the aneurysms. Look at this patient, a young male patient. He has a right-sided acute onset ptosis diplopia. And he also has history of seizures. So it's a case of a right-sided third nerve palsy. But he also has history of seizures, so definitely neuroimaging is indicated. And what we see in this, that there are multiple ring-enhancing lesions. So these ring-enhancing lesions, one was also noted in the midbrain, and this was possibly why the patient had the third nerve palsy. So multiple neurocysticercus in the brain. Intracranial aneurysms are very important and life-threatening cause of third nerve palsy, especially if the palsy is painful, pupil involving, and complete palsy. So remember that you have to rule out by not just doing MRI, but also get a MR angiography or a CT angiography done. And most common would be a posterior communicating artery aneurysm. Now, pupillary involvement in third nerve palsies are associated with compressive lesions. Why? Again, have a look at the anatomy. We all know this. Pupillary fibers are present superficially. So, any compression will cause a pupil involvement. But if there's a medical or a ischemic lesion, ischemic palsy, then the involvement is mostly of these vessels, which is here supplying the vasa nervosum, which is supplying the main trunk. So, here it's mostly pupil sparing. Okay? But there are exceptions to it. Remember, it's not a hard and fast rule. And what type of involvement you see in third nerve palsy? It's usually mid-dilated, non-reactive pupil. She's a young female patient presenting to us with right-sided pupil involving complete third nerve palsy. So, of course, an indication for neuroimaging. And we find this huge lesion, which was affecting, that was causing the compression, affecting the cavernous sinuses as well. So if there is a cavernous sinus involvement, remember that there will be multiple cranial nerve involvement, because in the sinuses you have third, fourth, fifth, sixth coming together. If there's an orbital involvement, you will have the orbital signs present, like loss of vision or proptosis. She is an elderly patient, had uncontrolled diabetes, presenting with this drooping of the lid. So it's a complete third nerve palsy, yes. Most likely it could be ischemic, but have a look at the vision. She also had a decrease in vision, there was proptosis, and there is disc edema. Okay, look at the proptosis. Compared with the other eye, there's a mild proptosis. So because of these signs, we suspected something in the orbits. So we got this imaging done, and what we found was that the patient has a non-specific extensive inflammation. So it was suspected it was probably fungal infection. So they did the smears. It was found to be positive for mucormycosis. Now, especially after COVID, a lot of mucormycosis cases were seen. Aberrant regenerations, yes. Now, how does aberrant regeneration occur in third nerve palsy? Whenever there is a breach of the endoneural sheath. So this breach can happen only if there is a slowly growing tumor, trauma, or congenital cases. So if not congenital, you should rule out a tumor by doing a neuroimaging. Fourth nerve, it's mostly, congenital in nature, the palsies. And if not congenital, most likely it's traumatic. Why? Because it has a unique course. It completely decussates to the opposite side. It emerges on the dorsal aspect of the brainstem and then crosses on to the all around the brainstem to come on the ventral aspect. So that's why it's susceptible to trauma. So mostly in traumatic cases you see. But remember the case that we discussed in the supranuclear palsy where the patient had a bilateral superior oblique palsy caused by a hydrocephalus. So remember that even exceptions do exist, and so you should keep these unusual pathologies in mind. So now next is the sixth nerve. Now sixth nerve, what is interesting is that, it has a very protracted course. It takes a double angulation here. As it emerges at the cerebellopontine angle, it takes a double angulation, a 90-degree turn here, and then before it enters the Dorello's canal. Now, because of this double angulation that it takes, it's susceptible to compressions because of raised intracranial pressures or CP angle tumors. So that's why even sixth nerve palsy, you have to rule out the CP angle tumors. So this we have already discussed in the first case, horizontal gaze palsy, seventh nerve involvement. All this is suggestive of a nuclear involvement in the pons. Fascicular involvement, again it will have brainstem signs because there's a pyramidal tract which is going along with the sixth nerve has an association with the pyramidal tract. Subarachnoid space, remember there are several causes, but raised intracranial pressures can cause a sixth nerve palsy here. So that's a false localizing sign. So do remember to check the fundus. Then I think all these things you can go back and read. This is all theory. So we have this elderly female patient who presents to us with the right-sided sixth nerve palsy. Yeah. So although it could be ischemic, most likely it could be ischemic, she did not have systemic illness. We went ahead because it was acute onset palsy. We did the imaging and we found this huge right-sided internal carotid artery aneurysm. So, it's not unlikely to find these things in elderly patients. Now, this has already been discussed, bilateral sixth nerve palsy with the edema. That's raised intracranial pressure. It could be anything, venous sinus thrombosis, IIH, or a huge space occupying lesion. So you just check the fundus. Don't miss that before referring the patient. So these are indications of neuroimaging in cranial nerve palsy, but just to simplify things, all acute onset cases of palsy should undergo neuroimaging. Then, this is a young female patient. She has a left-sided total ophthalmoplegia. Now this side actually it's not, but there was a limitation in adduction as well. So there is a total ophthalmoplegia if you see. There was a decrease in vision and some congestion. So where do you localize the lesion? Cavernous sinus, there's also decrease in vision. Orbital apex. So when there's a decrease in vision, you should localize it to orbital apex together with total ophthalmoplegia. So what we noted was a huge trigeminal schwannoma that was compressing the orbital apex and also the sinuses. So since there was some cavernous sinus involvement, that's the reason why she also had congestion. Okay. Just myoneural junction disorders in brief. So this is a young patient. What do you see over here? So it's a, so this is a ptosis which is progressively increasing with sustained gaze. So this is suggestive. Yes, I heard the answer somewhere in the audience. It's a case of myasthenia. So just remember, do a ice pack test, especially if the ptosis is present, you can do a ice pack test. Patient markedly improved with this. So it's a case of myasthenia. It's an autoimmune disease, we know. Ocular myasthenia commonly presents with ptosis and sometimes also with diplopia. These are the tests with which you can confirm your diagnosis. Neostigmin test, ice pack test is possible only in ptosis patients, and the other being your nerve stimulation and your single fiber electromyography, which is the most sensitive test. This is also quite an evident diagnosis and has already been discussed. You see extensive proptosis, extensive proptosis with limitation of gaze and all the limitation of movement in all the gazes, tendon sparing. But remember what you have to check in this patient. Compressive optic neuropathy. So do check for the fundus, get the visual fields of the patient on regular follow-up. Okay? Do not miss that. Now this is a youngish female, female patient. We see a left-sided sixth nerve palsy, but you also notice this conjunctival congestion and you also see a periorbital edema. So you're suspecting something is there in the orbits. So we get an orbital scan done, and what do you see? It is a huge lateral rectus cysticercus. So you see the management would be totally different depending upon the cause. So bas, I would like to conclude by saying that there could be array of causes for your motility disorders, but clinical evaluation, careful clinical evaluation is the key to diagnosis, and just remember the anatomy. If you know this, you can tailor your investigation, especially neuroimaging, and you can actually guide the radiologist that where to image, what to do. Okay, thank you.
Thank you, Rebecca. I'm sure by discussing limitation of motility, you have actually shaken and stirred the entire audience up, who were, I think, feeling a little sleepy before the onset of this talk. Wonderful, excellently presented. Any question, one or two, we could take related to motility defect before we move on to pupils and anisocoria? Dr. Amar, again, another young faculty. His forte is imaging of the orbit, his experience in that, in the OCT, angio, UBM is phenomenal. I think there are hardly too many people in the country who would match with his understanding and experience. So he'll be telling us about approach to anisocoria. Pupils, again, another very, very important aspect of examination and localizing disorders. Dr. Amar.
Thank you, sir. Good afternoon, everyone. So I will be talking on approach to anisocoria. So what is the purpose of pupillary testing? We need to test the pupils because it's going to tell the pupillary function, how the muscles are acting, the sphincter pupillae and the dilator pupillae, and it tells about the afferent system, the optic nerve till the lateral geniculate body, and it's going to tell about the autonomic innervations of the eye, as Dr. Rebecca was telling about the compression by the posterior communicating artery aneurysm or other conditions. So what is anisocoria? Any difference in the size of the pupil is going to be labeled as anisocoria. So we might be having a physiological anisocoria, a slight difference in the pupil size, So you can ask what is the amount of anisocoria which you are going to label as anisocoria which is significant. So up to 0.3 or like even 0.8 millimeter you can say this is physiological. Anything beyond 1 millimeter or 2 millimeter you can consider. Depending on the text, somebody might mention 1 millimeter difference is going to be significant. Somebody might mention more than 2 millimeter difference is going to be significant. But you should be assessing the patient visual acuity, what is his need when it is coming. So what is the patient's systemic status, what is his concern. So based on that one, you can just understand the cause and you can just investigate. So this is just to show the parasympathetic innervation of the eye. So you can see here, whenever we are going to throw the light, it's going to go through the optic nerve and the optic tract. So it's going to get relayed in the pretectal nucleus, where it is going to have bilateral representation in the Edinger-Westphal nucleus. So here it starts, the pupillar fibers are going to travel along the third cranial nerve and they are going to get relayed along the ciliary ganglion on each side. So from there, post synaptic nerve fibers are going to relay along the short ciliary nerve and they are going to innervate the pupillary fibers. So this is sympathetic pathway. There is a hypothalamus from where the first order neurons are going to descend along the brainstem and the superior part of the spinal cord up to C8 or T1, T2 or T3, where we are going to get ciliospinal center. So from where on the ventral side, the second order neurons are going to exit and they are going to have a close relation with the lungs, subclavian artery and other neck or the lower neck or the upper thoracic organs. So from there, the second order neurons travels upwards along the internal carotid artery, and here there is a superior cervical ganglia. So from there onwards, there will be third order neurons which are going to have intimate relationship with the internal carotid artery, and they are going to have a short relation with sixth nerve also. Then V1 branch of the trigeminal nerve, which are going to relay the ultimate fibers of the third order neurons of the sympathetic nerve fibers, which are going to travel along the long ciliary nerve and which are going to innervate the dilator pupillae. So why should we be worried about like such a small finding? Anisocoria is very insignificant. If you look at the patient is very fine, but it can be having a very life-threatening condition. So that's why we should be worried. And as I said, there is a certain range till where you want to label it as a physiological, right? So after that, you are going to label it as a pathological, and we need to take even this small finding very significantly. So what are the local causes? Let's go from local to systemic. So what are the local causes? There could be pupillary abnormalities, which could be congenital or like iatrogenic ones. So when there is a pupillar abnormality, you just need to compare on both the sides. So you might be having a coloboma, which could be unilateral. Of course, it is often it is bilateral. So if you are able to find these kind of conditions, you just need to assure them, right? So aniridia, patient might be having poor ocular surface, nystagmus, foveal hypoplasia, right? So, and a very large pupil. So again, you need to diagnose it as an aniridia and you need to counsel them, or you can just go for anodic IOL. So here, ectopic pupil, that is again congenital conditions, right? So in those conditions, again, you need to assure them and don't need to panic. And traumatic conditions, whenever there is a tear of the iris, you can just go for pupilloplasty, or you can just counsel the patient, or depending on the need, if he is having excessive need, you can just address based on IOLs or like any other pupil repairing surgeries. So if there is an inflammation including iritis or like anterior uveitis, so you need to address them and you need to send to retina this thing by giving some cycloplegic and pupil mobility drugs. So how to approach all these cases? You need to understand the anatomy, as Dr. Rebecca was saying. In Neuro-Ophthalmology, it is all anatomy. You need to understand where we are dealing and what we are dealing, what structure we are dealing. So take a proper history. What is the proper previous history, including systemic, any trauma to the eye, any recurrent redness in the eye. So do a clinical examination even on torchlight, as well as slit lamp examination is much more required. So after that one, you are going to label that particular condition either as physiological or pathological. If it is physiological, so you are going to assure the patient. So just observe. If it is pathological, you need to send them to either like UVA clinic or retina clinic, and depending on the cause. So it is sometimes we do use medications for dilatation, or most of the times, but sometimes patient might be using them on their own, right? So they might end up with some medications, self-medicating. So in those conditions, you might encounter a mydriatic pupil or miotic pupil. Here you need to understand what is the probable medication they are putting. Anticholinergics or sympathetomimetic can cause mydriasis, or parasympathetomimetic like pilocarpine or like OP poisoning, organophosphorus poisoning, can also be having a miotic pupil. So you need to understand the anatomy, take proper history, do a clinical examination, and then try to think whether we need to intervene or not. It's just observation, reassurance, or like specific testing is required or not. So third one, as Dr. Rebecca was saying, oculomotor or third nerve cranial palsy. So whenever there is a classical third nerve palsy, we are going to have an exotropic as well as hypotropic position of the globe and upper lid ptosis as well as a dilated fixed pupil, right? So here again, if you are able to understand this sensitive concern regarding when there is an aneurysm along the posterior communicating artery which can compress the autonomic systems along the third nerve, which are like nothing but pupillar fibers which are lying around the or like corners of the third nerve, so which can compress the pupillar fibers, and mydriasis or like isolated pupillary dilatation could be the initial finding rather than having a full-blown third nerve palsy. So another important thing is Horner syndrome. We have Horner syndrome and Eddie's people. These are most important things with respect to anisocoria when you are assessing or when you are studying neuro-ophthalmology, right? So Horner syndrome is nothing but, as I said previously, the sympathetic pathway from hypothalamus till the dilated pupillae. So the sympathetic pathway is going to supply the Muller's muscle in the upper lid. So when it is pulsed, you are going to get a mild amount of ptosis, around 2 millimeter, right? So it's going to paralyze the pupillar fibers, dilated fibers. The pupillar fibers are going to, sphincter pupil is going to take advantage, and it is going to constrict the pupil. And at the same time, the sympathetic fibers are also supplied to the inferior lid retractors. So that is going to get palsy. So the inferior lid moves up. So that's why you are going to get apparent enophthalmosis. So you got meiosis, you got upper lid ptosis and apparent enophthalmosis. So in addition, if the lesion is beyond the superior cervical ganglion, that can disrupt the sweat gland supply to the on that side, particular side. So you can get even anhidrosis of that in that particular patient. So how to understand? Again, I said I explained the anatomy. You need to understand the anatomy, first order, second order, third order. So one thing is like confirming, clinical confirmation. Yes, this is probably Horner syndrome, and taking a history whether they have any kind of neck trauma, any hypertensive neck dissection, right? So any injury to the neck, or there could be excessive cervical rib, or they might be having any cuff or expectation or hemoptysis. So anything related to lung, right? So they might be having any demyelinating diseases. So you need to take a proper history and do examination according to that one. So after that, you want to confirm it, right? So once you diagnosed it, yes, probably this is my probable diagnosis. You need to verify it by doing either pharmacological testing or by imaging. So what are the pharmacological testing? So what are the medications we are going to use? Some people say even cocaine is used 5%, 4% or 10%, right? So it is a high concentration. How it acts? So we are going to put cocaine medication, it's drops, right? So you are going to put in the inferior congenital sac. So after like 1 hour or after 60 minutes, you are going to assess the pupil size. So I am normal. If I am going to put cocaine in my eyes, so it's going to dilate the pupil. How it dilates? It inhibits the degradation of the norepinephrine, and it facilitates action on the postsynaptic nerve fibers, right? So if you put it in normal patients or normal subjects, you can get a pupillar dilatation up to 2.5 to 3 millimeter, right? So in Horner syndrome, when patient is having Horner syndrome, or that is first order, second order, third order, any kind of nerve insult, so it's going to cause a dilatation of the pupil which is going to be less than 1 millimeter. But you are going to put in other eye also, that is going to be your control eye. So you'll get around 2.5 to 3 millimeter dilatation of this eye, and this eye which is having miotic pupil because of Horner syndrome, it's going to dilate very less, right? So probability was like 1 or 1.5 millimeter because of meiosis, and it went up to 2 or 2.25 millimeter, but it went up to like from 2 to plus 3, almost like 4 to 5 millimeter. So there is more than 1 millimeter difference, right? So because of that, if you are going to get more than 1 millimeter asymmetry, that is probably indicative of Horner syndrome. That is first screening test, right? Second thing is like sometimes cocaine is not available. I don't know in this thing, but in Western countries it's available more illegally than illegally. So when you are going to put cocaine, the concern in American neurologists, it's going to be there in urine for almost 2 to 3 days, right? So if they are like stuck somewhere, like that can be legally problem. So that's why they issue a certification whenever they do a cocaine test. So here, like it's very difficult to get cocaine also, but apraconidine, it's an anti-glaucoma medication. It's available very easily, so you can put that one. It's going to be apraconidine, nothing but it's a selective alpha 2 agonist. So more preferentially, which is going to act on alpha 2 rather than alpha 1. So what it causes is whenever there is an injury to first or second or third order neurons, there is going to be something called denervation hypersensitivity. So between the nerve junction and the muscle fibers, the postsynaptic nerve fibers or the receptors are they have become more sensitive. So even if you put small amount of medication, they are going to act very rigorously. So that's why there is a post denervation. Nerve is not functioning, there is a hypersensitivity. The moment you put apraconidine 0.5% or 1%, which is very diluted concentration. So that's why the hypersensitivity will take advantage, and that is going to dilate the pupil. So it is so hypersensitive that even when you are going to put medication in the Horner people, it can go beyond the normal eye. So normal eye can be less reactive, but because of degeneration hypersensitive reaction, the Horner people might dilate even like more than 5 millimeter. Right? So that is like how you are going to suspect Horner's. Yes, I am doing cocaine test or precludin. So probably it is Horner syndrome. So now we want to locate, because it's coming from hypothalamus still like orbital apex, right? So we want to localize. So to localize, you can use hydroxyamphetamine 1% or phenylephrine 1%, right? So how it causes, how it acts, hydroxyamphetamine. Again, it releases the norepinephrine from the third organ. It stimulates, release more norepinephrine along the synaptic cleft, right? So when you are going to put hydroxyamphetamine, when the third, this is first order neuron, this is second order, and this is third order. So when third order neurons are intact, the hydroxyamphetamine will facilitate, release more norepinephrine in the synaptic cleft. That's how you are able to dilate the pupil. So if pupil is dilating after putting hydroxyamphetamine, it means that third order neurons are intact. But you are getting Horner syndrome in the first test. So that means that probably the lesion is along the first or the second order neurons. By putting hydroxyamphetamine, if you don't get any dilatation, that means third order neurons are dead. That's how they are not able to secrete the norepinephrine in the synaptic cleft. So that's why the lesion could be along the first or the second order neuron. So nowadays, rather than going this one, so by doing cocaine test and upper test, you need to give some washout period. Then probably after 48 hours, you need to do this hydroxyamphetamine. So by doing all this one, you are able to say, yes, there is a Horner that I confirmed. Probably it is pre-ganglionic or post-ganglionic. That's it. But you won't be able to understand what is the exact cause. We need to address that one. It could be a dissecting aneurysm within like few days. So in those conditions, it is better to go for imaging nowadays. From hypothalamus till your orbital apex, you can do any amount of imaging, and you can identify whether it's a mass lesion or it's a demyelinating lesion or any kind of dissecting aneurysm. So all sort of findings you can get by doing imaging. So but you need to understand how the pharmacological testing of the Horner syndrome is done. So next one comes the Eddy's pupil. So here what happens is the pupil is dilated, right? So in Horner's the pupil was constricted, here the pupil is dilated. So what is the cause? Again, there are very broad causes. Majority of the times it is idiopathic, but sometimes there could be some kind of ciliary ganglionitis because of post-viral infection, or there could be some orbital tumor along the between the optic nerve and the lateral rectus. That's where the ciliary ganglion lies, right? So somebody might have damaged post-biopsy or post-orbital intervention, or there could be some kind of orbital infarction that has led to insult to the ciliary ganglion, and that's how the sphincter pupillae fibers have gone, and that's why your pupil is now dilated. So you need to confirm this one. So if you see the Eddy's pupil under a slit lamp biomicroscopy, you are going to see a very slow vermiform movement along the pupillary margins. So that's how the pupil slowly constricts and slowly dilates, right? So you need to search for the cause, orbital cause. If you are not able to find anything, you are going to label it as a idiopathic cause. And in this picture, you can see that like patient is having a poor response to light, right? So it's not constricting to the light, right? So because the pupillary fibers or the parasympathetic fibers are gone. So but he is able to converge. Why he is able to converge? Sorry? Which pathway? Convergence? Accommodation? So again it has to get related to the third nerve only.
Sir, actually at the level of ciliary ganglion, the ratio of fibers responsible for accommodation convergence to the ratio of fibers for near reflex, it's 30:1. So in case of ciliary ganglion damage, it's very likely that accommodation fibers are relatively spared as compared to light reflex fibers. So that's why accommodation is relatively normal as compared to.
But when you're accommodating, the cilia body should contract. Why the pupil is contracting here? So what happens is here, like whenever there is a ciliary contraction for near this thing, so there are two hypotheses. One thing is like whatever the degeneration hypersensitivity I said. So whenever there is a loss of nerve supply to the sphincter pupillae, some fibers from the ciliary body they are going to trying to innervate whatever the misinnervation, or like she was saying, Dr. Rebecca. So some fibers from the ciliary muscle they can innervate the pupil. So when patient is trying to converge or accommodate, the pupil will also try to contract. Not because of pupillary fibers, the fibers which are coming from the ciliary body. That is one hypothesis. Second hypothesis, some people say that like whenever there is a convergence response, right, so accommodative response, so there is some amount of acetylcholine which is released from the ciliary body into the aqueous, which comes to in the antechamber, which stimulates the pupillary fibers. So that's why it takes some time to constrict. It's not instantaneous, right? So these are two hypotheses. Again, we need to explore that one, but this is logical sense. So whenever you get this kind of pupillar asymmetry, you need to do dilated pilocarpine test, because those people are going to be very disabled for near vision, right? So they are not going to be good. So in those cases, you need to put diluted pilocarpine. So if the pupil is constricting, then you are going to prescribe that one as a therapeutic measure also. But sometimes what happens is patients are going to be who are going to be very active. I have few male patients who had this kind of problem. I prescribe, but they said that when I go to a dark room, I'm not able to see everything. My dark room activities are disabled now. So this is one more condition where left eye you can see after putting pilocarpine development, it's not constricting. Right eye is constricting, but left eye is not constricting. You can see there is a ectropion of the pupillar margin. The whole iris looks dysplastic. It is not properly developed. So even though patient had a subnormal near vision, but he did not have classical Eddy's pupil, and he is not going to get benefited by prescribing the diluted pilocarpine. So we just counsel them. Right. So newer entities which are rare causes of anisocoria, there's something called, these are not common, but trigeminal autonomic cephalalgia. So here primarily patient will complains with they will present with significant headache, right? So in addition, depending on the sympathetic or parasympathetic overactivity, you can have lacrimation or meiosis, right? These kind of changes could be there. Other condition is autoimmune autonomic ganglionopathy. So again, these are certain specific antibodies because of the autoimmune reaction which are produced against the ciliary ganglions or some ganglions in the brain. So again, they can have sympathetic or parasympathetic. They can be have meiotic or mydriatic pupil. So in addition, they are going to have other autonomic system dysfunction like orthostatic hypotension. So you need to take a proper history, then you can make probably whether the anisocoria is significant or not. So in this way, if you are going to test the meiotic or mydriatic people in a very systematic manner by understanding the anatomy and by correlating the clinical findings, right? So you can just make some contribution whether he needs specific treatment or he just needs observation, right? Thank you.
Thank you, Dr. Amar. Again, a very difficult thing, nicely summarized and classified. We are now at the end of our didactic, partly interactive discussion. We have two very interesting what should I say, activities lined up. One is a visit to our neuro-ophthalmology lab. We are grateful to RP Center to give us a nice exclusive area where we can do some detailed and more specific workup in the neuro-ophthalmology lab. So anybody who's interested to have a visit, we have our set of people there, our very good energetic optometrists who give us the excellent backup in the investigations, and our senior residents and of course faculty will be there to assist you through any understanding you have about the lab. And of course the other alternative very interesting activity is the lunch. So you have to choose what is more to your taste, let's put it. So we're open for questions. Dr. Rebecca here will be you can contact anybody who wants to have a look at the lab, so that we just thought we'll stagger it. So a few can go to the do the first interesting activity first and come back and do the second interesting activity and vice versa. So Dr. Rebecca here, anybody interested can please just talk to Rebecca so that we can or any of our senior residents, so that we can kind of plan your visit. It's a little away on the OPD first floor, room number 135. Yeah, and we can take questions in the meantime. Yeah, Rebecca, you can just stand up and so that people can, our senior residents, anybody who wants to be interested to have a look at our lab. So, and questions if any. वेरी गुड. हाँ एक बार लैब में चक्कर मारते हैं. सास को भी बोलते भाई तुम भी जरा ओकेजनल विजिट टू द लैब मार लो. उनको